Welcome, everyone. Good afternoon. Okay, I see people are coming in. So good afternoon, everyone, and good morning to those on the other side. It's a great pleasure for me to welcome you to the Nigerian Social Norms Learning Collaborative Conference. The theme of this conference is empowering women through policy and practice related to social norms in Nigeria. The conference will hold for today and tomorrow through 1:30 p.m. to 5:05 p.m. West African time. And for those on East African time, that will be 7:30 a.m. to 11:05 a.m. I want to thank everyone, each and every one of you on here for making time today. And I'm very pleased to welcome those of you who have been part of the Nigerian Learning Collaborative, and also those who are new to the Nigerian Learning Collaborative. I'll be giving a little background on what the Social Norms Learning Collaborative in Nigeria is all about in a few minutes, just before we go on. Next slide. So just before we go ahead, I want to take some time to acknowledge the Honorable Commissioner of Health for Kaduna State, who will be joining us, and also other high-level dignitaries or participants who are here. Next slide, please. So while we're waiting for others to join in, we kick off fully. We want to run a poll quickly. If you're in here, please the chat. Sorry about that, Meredith. Let's start with the chat. Please, for introductions, because we are so many in here and I doubt we'll have time to go around. We do want to get to know everyone as much as possible. It's now that we're in different times, it's unfortunate that we're not meeting in person. So please do take time to use the chat function. Let's know your name, your position, and your affiliations, where you work. And in just one sentence, let us know what you hope to get from this conference. I'll start by introducing myself since I'm speaking. My name is Mikhail Aliu, and I'm Director of Programs with MSpace. So while we're doing that, we can move to the next slide, which will be a poll. That's great. I see some want to learn about the Learning Collaborative. I'll give a brief overview after this, and I'll share some resources which we can look through during or after this session. So yes, you should be seeing a poll that has been launched right now, and it says, which area best describes the focus of your work? We have a few themes which we have put, which I think it spans across for most of us here. So please go ahead and take that poll. It should be left running on your screens while we move to the next session, just to save time. Next slide. Just to mention that I'll be sharing the results of the poll, and just shortly after I give a brief overview of the Learning Collaborative. So for today's agenda, we'll be starting with the opening session now, which will be rounding up with the remarks from our funder, the Gates Foundation, and also the Honorable Commissioner of Health for Kaduna State. And then we'll be having 3 sessions today. The first session on maternal and child health and nutrition, and then we'll have a short break, and we'll return for section 2, which will be on responsive feedback, and then section 3, which will be on faith-based social norm shifting. Next slide. So about the Nigerian Social Norms Learning Collaborative. The collaborative comprises of representatives across governments, donors, NGOs, and people and stakeholders that with vast interest around social norms programming and research in Nigeria. The major objectives of the Nigerian Learning Collaborative is 1, to document and share experiences, 2, strengthen capacity of those who are involved in implementation of these programs and the research ongoing on social norms, and to improve practice through partnerships. So at the moment, we have a committee of practice which comprises of members, and these members, some of them have been involved in some capacity building workshops, also in some mentoring, and just cross-learning and sharing across organizations on what we do in our various fields, in our work in social norms, in our various areas. And the last objective of the Nigerian Learning Collaborative is just creating that resource and products that will support the work which is ongoing in the field. Next slide. So because of time, I won't touch much. There's a lot to say of which about the ongoing work which has been taking place over the past few years. But however, to get more information on the Nigerian Learning Collaborative, we're going to be sharing, there's a link. You can also get this link in the chat box right now. I'd like to say for those who are interested to please sign up to be part of the mailing list. There you have access to resources and information on future events and as things come up. So at this point, let me take some time to, okay, just before I share the polls, let me go. I see some people are still taking the poll. So I'd like to take some time to appreciate those who have been working behind the scene and those who are the conference organizers as part of the Nigerian Learning Collaborative, including Hasbi, who is also Hasbi Allah, who is also with MSpace, and then Rebecca, Marilyn, and Meredith, who are from the Center of Gender and Equity and Health of the University of California, San Diego, and of course, Betsy, who is with FHI 360. Now, before I go into the setting our usual ground rules, I see most people have taken the poll, so let me just end the poll and share it at this point. Now, this is just, you see, we have a diverse group here, and it spans across, I see, from mostly women's rights and economic empowerment and gender-based violence. But what's important here is to show the diversity in the group. And just to touch on, this is equal to the nature of the diversity we have in the Nigerian Learning Collaborative. And one of the strengths of this collaborative is how we can draw on each other's learning from different fields and apply that to our ongoing programs and also upcoming programs. As I mentioned, some of the objectives earlier of the collaborative is to engender that form of learning and sharing across the work we do. So setting the ground rules for today, I'd like to ask that, these are things that we I think most of us have come to know in recent times due to the new norms we have. I'd like to ask that participants stay muted through the conference. If you have any questions, you can place them in the comment box. Or if you have any questions, you can use the raise your hand function. And when we have the Q&A sessions, you can use the raise your hand function. For logistics, we'll be very strict with timing because we know that everyone has a busy schedule and we try to keep everything within the time. We'll be having short breaks on day 1 and day 2. For today, we'll have that after the first session. Please, for those who are presenting, please ensure that you keep your eye on the time for when you'll be presenting. In case you have to step out, make sure that you're aware of what time you'll be presenting so you're back. We'll be giving short prompts to each individual that's presenting by a direct message to let you know once your time is nearing the end. Next slide. So at this point, I would like to call on one second. Okay, I'm just checking the participants list to see who is here. I'd like to call on Fatima Akali, who is with the Bill and Melinda Gates Foundation, to give an open remark. And after Fatima, we'll be having an open remark from Dr. Amina Baloni, who is the Honorable Commissioner of Health from Kaduna State. So Fatima, over to you.
Good afternoon. Just to check that you can hear me.
Yes, we can hear you. Thank you.
Okay, thank you. Partners, ladies and gentlemen, good afternoon. I was going to say, please permit me to stand on existing protocol. Then I realized that I'm the first speaker, so I'd probably have to create that protocol. But so distinguished guests, good afternoon. It gives me great pleasure to see you all here today and to represent the Bill and Melinda Gates Foundation at this Learning Collaborative Conference on Social Norms. Today's theme, Empowering Women Through Policy and Practice-Related Social Norms, is one that speaks to one of the major priorities of the Bill and Melinda Gates Foundation, and we are excited to participate in the learnings that will emerge from our interaction. The Bill and Melinda Gates Foundation is proud to partner with the Learning Collaborative to improve programming and research that address social norms that influence the success of development programs in Nigeria across multiple sectors. This is done with an objective to advance implementation of normative interventions to increase well-being of adults and girls and their families, to improve government-funded demand strategies and tactics, to improve patient targeting and engagement, to increase empowered decision-making by women within the family planning priority geography. Sorry, that was a mouthful. And lastly, to develop clear understanding of which policies are harming and which ones are helping progress for women in Nigeria. We at the foundation are pleased with the progress that's been made so far, and we're greatly encouraged that the community of practice working on social norms and demand-centered programming will help in shifting social norms, including gender norms, that will enable women to take a more active role in decision-making in their households and communities. We look forward to the outcomes of this partnership, equipping local, state, and federal governments to develop better social behavior change interventions. So then we ask, how does this work and today's theme tie into our priorities at the Bill and Melinda Gates Foundation? At the foundation, we believe that all lives have equal value. We envision a world where every person has the opportunity to live a healthy and productive life. Our 4 priorities are to ensure more children and young people survive and thrive. So to do this, we believe the path out of poverty begins when the next generation can access quality healthcare and a great education. We act with focus on nutrition through food fortification, addressing preventable childhood diseases through immunization, and helping Nigeria meet its overall human capital development goals. Our second priority is to empower the poorest, especially women and children, to transform their lives. We believe that by giving people the tools to lead healthy, productive lives, we can help them lift themselves out of poverty. This is done through boosting financial and social inclusion, human capital development strengthening, and improving maternal and child health. Our third priority is to combat infectious diseases that particularly affect the poorest. We believe we can save lives by delivering the latest in science and technology to those with the greatest needs, and this is done through health system strengthening, stewardship, and collaboration through the Basic Healthcare Provision Fund. Our fourth priority is to inspire people to take action to change the world. Now, we know that our resources alone are not enough, so we work to change public policies, attitudes, and behaviors to improve lives. Ladies and gentlemen, I am sure you will agree with me that these are shared objectives, and we must put people, lives, and livelihoods on the driving seat of our operations. Understanding how social norms affect the delivery of these priorities should remain firmly rooted in our minds as we continue to strive towards an enabling environment for every Nigerian to survive and thrive. As one of Nigeria's foremost development partners and friend, I'd like to reaffirm the Bill and Melinda Gates Foundation's commitment to supporting Nigeria in meeting its development objectives. In line with our strategy for 2022 to 2025, we will continue to enable and empower local institutions and partners to improve the development outcomes through innovation, evidence-based approaches, and building potent partnerships. The next 5 years will be a period of integration, consolidation, and acceleration. We look forward to 2 days of learning about the journey of the Learning Collaborative, as well as various research findings that will inform future interventions. It is my hope that we leave this room with a stronger resolve to collectively work towards strengthening our understanding of behaviors and practices and how to shape them to inform the design of responsive interventions. I thank you for your time. Thank you.
Thank you. Thank you very much, Fatima, for that great opening remark. If we were in person, this will be the time when we'll give a round of applause. But I'd like to ask everyone to, I see in these days we can use the reaction to please give a round of applause with the reactions to Fatima for that wonderful opening remark. I think as was stated, one thing we can say across everyone here is that we're all here because we have that shared responsibility or shared interest in the social work which is ongoing in Nigeria. And for me, for I individually, I think that's one thing I'm hoping to get out from today, to also see what's going on and see what we can apply from the learnings into the ongoing work which we do in my organization. So at this point, I'd like to move to the next opening remark, which will be from the Honorable Commissioner of Health of Kaduna State, Dr. Amina Boloni. Dr. Amina is represented by Dr. Hajara Kera, and Dr. Hajara Kera is the Director of Public Health in Kaduna State. Dr. Hajara, you're welcome. Over to you.
Okay, thank you everyone. Good afternoon. I bring you greetings from Kaduna State, and it's a wonderful thing to be here today and be part of these discussions as we move on and move forward in improving and empowering women to contribute positively to our society. So luckily, I get to stand on the existing protocols, and I will be administering the welcome address as I have been directed by my Honorable Commissioner. She wished she could have done this herself, but we have some other higher level engagements that she has to conduct personally. So, so I begin to read. Empowering women through policy and practice-related social norms in Nigeria. All protocols duly observed. When the issue of women empowerment comes into social or political discussions, the first thing that comes to mind is the distribution of money and palliatives from both the project initiator and receiver. This is because such kind handouts have helped many women meet their immediate economic needs, like boosting their businesses, providing food for the family, and they can meet immediate needs. But beyond this, empowering women with other critical knowledge and valuable social norms in these times has become even more important to make the necessary changes in society. These include relevant engagements that will have a robust impact on policy formulation as well as implementation. Therefore, I must say that I'm impressed and very excited about this event because it is one of the much needed to discuss policy and practice related to empowering women. I commend the organizers, the Bill and Melinda Gates Foundation, the community of practice, and the consortium for this conference and for nominating me as the keynote speaker. This conference will set the ball rolling on empowering women through policy and practice related to social norms. The leadership of Kaduna State and to a certain extent Nigeria has demonstrated willingness to involve women at the highest level of policy formulation and governance. I hope that through engagements like this conference, we will not only appreciate the efforts made towards equality in opportunity, but strive towards achieving equality of outcomes regarding women's empowerment. Before I hand over to my dear colleague, Mrs. Beatrice Elwaka, to tell us more about the conference, I wish to express my delight that from the speakers selected and issues to be addressed, the outcome of the sessions will be enriching. I'm hopeful that we will all be equipped with knowledge on the proper approach to improve our health and well-being, as well as empower our women through enlightenment and economic independence, as well as acquaint ourselves with the prevailing social norms. Women's empowerments are all great efforts geared towards promoting women's sense of self-worth, their ability to determine their own choices, and their fight to influence social change for themselves and others. Policy is a deliberate system of guidelines to guide decisions and achieve rational outcomes. Social norms are the unwritten rules of beliefs, attitude, and behaviors that are considered acceptable in a particular social group or culture. Gender equality in Nigeria was observed by the Global Gender Gap Report of 2021 on 4 main dimensions. 1, access to economic opportunities. 2, education. 3, health. And 4, political power. The gender gap in political empowerment remains the largest of the 4 gaps in Nigeria. In Nigeria, women are generally marginalized in governance representation at both national and subnational levels. For instance, in Nigeria's 2019 elections, 7.3% of the Senate and 3.1% of the House of Representatives are women. There are no state governors that are women. In the 2021 Gender Gap Report, Nigeria ranked 149th out of 156 countries in terms of the gender gap in political empowerment. United Nations Women, UN Women, ranks Kaduna State as the best performing state in terms of women participation in governance, translating to about 43% women representation in governance. Impacts of women in governance. Countries headed by women were found to be more effective in handling the COVID-19 pandemic than countries headed by men. A good example is New Zealand versus Spain and Germany versus the United States. Kaduna State government's success in the handling of the COVID-19 was attributed to the effective leadership of a woman in place of our Deputy Governor, Dr. Hadiza Balarabe. Evidence suggests that the more women in leadership, the more prosperous society can be. For example, New Zealand with a Prime Minister Jacinda Ardern, Germany Chancellor Angela Merkel, Liberia, who had the first female president, Ellen Johnson Sirleaf. The barriers to women participation in governance, however, are linked to issues around discrimination, which is sponsored by social, cultural, and misinterpreted religious norms of the society. Men are the majority and they dominate in political parties and most activities. We also see a lack of adequate education of girls and women in northern Nigeria that prevents them from having the adequate skills enough to step up to be and participate in governance. The elections, the violence that take place during elections include violence against women candidates, which is also a branch of gender-based violence. We see also that there's a lack of adequate financial support for women, as women usually devote more time to caring for their families and raising their children, and in that course have less financial resources available to them to participate in politics and governance. And then one of the last but not the least of these points is that women are largely marginalized when it comes to democratic processes. There have been situations where some women were denied purchasing forms to, participate as candidates in the democratic process. Factors that encourage women to participate in governance, however, on the other hand, include socio-cultural. For this to happen, we need a socio-cultural reorientation and sensitization of the public on the roles of women, geared at making it more acceptable for women to be in positions of politics, positions of governance. Women also need economic empowerment basically and majorly through education and technical training. The political interest and awareness needs to be developed in women, by women, and of course by the larger society, for women to really have the confidence to step out and be part of the process. The quota system is something that has helped the women, but this needs to continue so that the women have a certain level of a certain number of seats that are allocated to them. A good example is the affirmative action that has been taken to allocate a certain amount of political seats to women in governance. We also collectively need to discourage sexism and gender-based violence, of which in the recent years we have had a number of cases where aspirants have been attacked during elections. In conclusion, government policies and practices could be designed to display certain social norms that will put women and girls at a disadvantage in our societies. It would provide a level playing field and empower women to live to their full economic, educational, economic, health, and political potentials. Thank you very much and have a wonderful conference.
Thank you very much, Honorable Commissioner of Health for Kaduna State, Dr. Amina, fully represented by Dr. Hajara Kera. At this point, I'd like to ask that we give a virtual round of applause for that powerful opening remark, which was just delivered. I think more than ever, now I think is the time we put more emphasis on the importance of having women in leadership. Yes, I was going to say we can also use the chat function to also give a round of applause. There, it remains more visible to the presenter. Thank you for that, Isika. And I think that opening remark just gave a backdrop for the importance of this this conference. I think we cannot overemphasize the importance of having more women in leadership and in governing position, and not just women, but also young girls in taking such positions in families, in schools, and whichever sphere of life they are at the moment. So without much further delay, I'd like to hand over to Beatrice. Beatrice will be setting the scene for this conference and share with us the objectives of the conference and the importance of having this conference. And Beatrice, once after this session, we'll be handing over into the next section. So Beatrice, over to you.
Thank you very much. Can you hear me? Am I audible?
Yes, we can hear you.
Thank you very much. And I want to thank the last speaker who spoke on behalf of the Honorable Commissioner for making my work a bit easier because she has extensively talked about the role of women in leadership positions and in politics. But let me go back to social norms. She also tried to define social norms, which we define generally as rules that are unwritten that guide social behaviors, particularly of groups, communities, traditions and cultures. And there are many of them. And many of these norms, social norms, have placed women as second-class citizens, so to speak. And that is why the theme for this conference is really very important to address some of the negative effects of these social norms. Let me also start by saying that the current situation we find ourselves, particularly in the rural areas, women lack education, particularly the young girls. We find a situation where in a family, where a girl has to drop out of school so that her male siblings can go to school. And if they manage to send the girl through secondary school, that is the limit. They want to go with that girl. And then she has to go to work to earn income to support her younger male siblings to go beyond maybe secondary school and so on. We still see these type of things in our communities, in the rural areas particularly. We see situations where women of childbearing age do not have access to health services. Not that the services are not there, but they cannot access because of the social norms. For example, women who deliver in health facilities are seen as very weak women. And therefore, so that they don't brand me as weak, I try to deliver at home. And of course, those of us on this platform know exactly what the result is. We have seen very high maternal mortality rates, high infant mortality rates, children dying, at birth and so on. These are some of the negative effects of the social norms we're talking about. Now, I will not go into the politics because the Honorable Commissioner has delved into it. But I just want to say that following the Beijing Conference for Women, the Women Affirmative Action was agreed upon. And I think the Beijing Conference said 35% of appointments should go to women and so on. But in Nigeria, with the National Gender Policy of 2006, we enshrined the Women Affirmative Action to be 35%. But I'm sorry to say that at federal level up till today, we have scored less than 7% of women in places where they should be in terms of leadership. However, 8 out of our 36+1 states of Nigeria have managed to go beyond the 35% affirmative action. So we still have a lot of work to do around here. So today's theme, like we said already, empowering women through policy and practice related to social norms in Nigeria, is a welcome development. And we have the themes, thematic areas that we have to discuss today include maternal child health and nutrition, women's economic empowerment, and gender-based violence. Gender-based violence is an issue of great concern for us in Nigeria, particularly with the COVID-19, where people now work at home, the new normal, and we see an increase in gender-based violence. We see an increase in wife battering and so on. And these are areas where I think we need to work very hard on to see what we can do to ensure that the law enforcement agents do what they are expected to do to guard against gender-based violence. When we talk about health, the reason that many people do not access health facilities is also because of the fact I said they are classified as second-class citizens. They have to take permission from their husbands before they can go to access health facilities. And also they need money to be able to go to health facilities, money that they probably do not have, particularly those women in the rural areas. And so where the husband is not available to give this permission, older women, grandmothers, mothers-in-law, also who believe that there was no need to go to health facility, stop these women from accessing health facilities. So what are we talking about? We need a lot of capacity building. We need a lot of sensitization. We need a lot of advocacy to traditional and religious leaders, and even government leaders too, so that they understand their roles and they do all that is within their power to ensure that we have funds available to do these capacity buildings and advocacy, and put in place guidelines that will help to improve the situation of women, which, when this happens, will automatically improve the quality of life of every member of the family, including the husband and the children, and everyone at large. So I think that I will not talk too much, and will hand over to Rainat, I hope I have the name correctly, who will take us through or introduce the speakers for the first thematic area, which is maternal child health and nutrition. And before I give up, I haven't said anything about nutrition. We know that the infant mortality rate or child under 5 mortality rate in Nigeria is quite high. And of 53%, as much as 53% of the deaths attributable to, to children under 5 is attributable to malnutrition. And we see a lot of malnutrition in various areas because women do not breastfeed as they should. Our exclusive breastfeeding rate remains low at 27%. And that is because of the norm that says that children need water. Yes, of course, children need water, but all the water that the child needs within the first 6 months of life is in breast milk. So these are things that we need to do to enforce, make sure that our mothers, particularly those in the rural areas, have the necessary knowledge and skills and are helped to also get empowered to be able to do what is needful to improve the quality of life of themselves and their children and the family at large. So over to Rainat.
Thank you very much, Beatrice. I think you have spoken truly to your area of expertise around nutrition, and that's fantastic because it builds for me the next reason why this session is very important. Hi everyone, my name is Rehana Ibrahim, and this first session is maternal and child health, nutrition and nutrition. We are going to be looking or discussing 3 topics, which would be led by Erica Sedlander, the Director of Research and Dissemination for the Department of Family Medicine at University of California. Please, a round of applause for Erica. Chidera Olivia Udiani is from University of Abuja Teaching Hospital, and Emily White will also be discussing some topics on this, and she is the Deputy Chief of Party for Breakthrough Research Nigeria. This session, as I said, is very important because the crux of our entire health system is centered around maternal and child health, specifically in primary health care. And the norms that we see, everything from family planning and contraceptive use to antenatal care, to delivery, postnatal care, and the entire continuum of care for the mother, and transmitting to the child from immunization to early infant illnesses, as well as nutrition, are all anchored around social norms. And as healthcare professionals, this is the part of gender and norms that would typically affect the outcomes that we see, we know that the core of our problems are really around demand in terms of getting people to even want to get this, or to even feel like it's important for them to get health services that are life-saving. And so this session is very, very important. The topics that we're going to be discussing, we're going to be rolling in from one topic to the other. And so we will be taking questions at the end of the 3 sessions. As the speaker is presenting their work, please feel free to include comments in the chat. And at the end, we'll also allow a Q&A time where a few people will also be allowed to speak, to ask their questions or make their comments and contributions. We have 3 papers, again, as I said. The first is on adapting gender norm skills and self-injection social norms in Nigeria. The second is on knowledge, attitude, and practice towards hospital delivery in Gwagwalada, among women in Gwagwalada. And the third is looking at the psychosocial influences on pregnancy and childbirth in northwestern Nigeria. And these 3 topics are very interesting, and I look forward to the conversations we're going to have on them, and they promise to be very interesting. So without further ado, I will hand over to Erica Sedlander to take us through the gender norm skill adaptation and examining self-injection in Nigeria. Over to you, Erica.
Thank you very much. Am I audible?
Yes, please.
Wonderful, thank you. Thank you very much for having me today. I'm really excited to be here. I've been working on social norms research for a while, but it's my first time working in Nigeria. So I was excited to hear about this conference, and I hope to learn a lot from you over the next 2 days. Today I'll be presenting on behalf of myself and my co-authors, Sneha Shala and Elizabeth Omuluabi. We're from the University of California, San Francisco, and Akena Plus Health, AK Plus. So I'll be talking about measurement. Clearly this conference understands the importance of gender norms and social norms. And the focus of my presentation will really be on how do we quantitatively measure these important concepts, and so that we can understand when they're changing and when they're being stubborn, and how can we, if we can quantify them and if we can measure them well, hopefully we can really understand when we're improving them, or as was just mentioned of COVID-19, when they're getting worse. So I'll talk about measurement of both gender norms and then social norms around self-injection of contraception. Next slide, please. So first I'll start with gender norms. The G norm is so there are calls in the literature to improve how we measure social norms. So there's a lot of calls to incorporate theory, both descriptive norms and injunctive norms. So descriptive norms are perceptions about what people are actually doing. My perception is that people are actually self-injecting contraception in my community. And injunctive norms are kind of expectations or how acceptable that behavior is, perceptions about that. There's also calls to include social sanctions, also, if people break those social norms, what is the consequence? And then lastly, to really use a reference group. So as we know, social norms are perceptions about what other people are doing. So we need to measure perceptions about other people, not our own individual attitudes and beliefs. So with the G norm, with this gender norms measure, we are doing that. So we originally developed and validated it in India and Nepal, and those papers are currently under review. And we're excited to adapt and validate the same scale in Uganda and Nigeria, a part of a larger study. And so to do that, we're analyzing qualitative in-depth interview transcripts from women of reproductive age in Nigeria and Uganda to really adapt, to really make sure that these gender norms items that we originally created in Southeast Asia are relevant in this new context in Nigeria and Uganda. So we've conducted 10 cognitive interviews, first in Uganda and next we'll do Nigeria. And we in those interviews, the interviewers are keeping memos, they're recorded, they're translated and transcribed. So with these cognitive interview transcripts, we can read through them and understand, are women really interpreting these gender norms items as we were hoping they would. So we're going to test out these items in both Enugu and Plateau, Nigeria, and then in Olam and Mayuge, Uganda, as part of a large longitudinal cohort. Next slide, please. So there's a lot of items we have right now, but I wanted to give you a brief look at what they actually are. So these are some descriptive norms items, and the stars are social sanctions, and I'll just read a couple. So the first is the reference group is most families you know, which is a proxy for community. So the first is, in most families you know, if a woman does not consult her husband about important decisions, it leads to violence. And this is on a Likert scale from strongly agree to strongly disagree. Or the next one is, in most families you know, if a woman earns money, it will cause problems in her marriage. So these are just, we have a lot now, and these are the descriptive norms. And if you can go to the next slide, please. These are some examples of injunctive norms. So I'll read the first one, which is also a social sanction. Most families you know believe that if a woman disobeys her husband, she should be sent back to her parents or sent away. I see a chat that there says there's no volume in this presentation. Can everyone hear me?
We can hear you, so that person may be having problems with their audio. We'll try to troubleshoot with them.
Okay, thanks, Meredith. And so, you know, these are items that came out of originally from Southeast Asia. A lot of these ones I just read actually are from Uganda, and we'll be testing these in Nigeria and adding new ones. But the gender norm scale is separated into two different subscales. So one is just descriptive norms, and the second is injunctive norms. So each item that we choose will be mirrored. So I'll have that same statement as a descriptive norm, perceptions, what people are actually doing, and then the injunctive norm, or expectations or acceptability of that behavior or attitude. So, you know, I wanted to have you take a look at these because we'd love feedback on these items or more. If we have time in the Q&A, I'd love to hear your perspective. Next slide, please. So the next steps for this is to refine these items based on cognitive interview feedback and discussions. We'll include these final items in the first wave of the longitudinal study with 1,400 women, both contraceptive users and non-contraceptive users. And then we'll be testing these items with psychometric analysis. So first, confirmatory factor analysis, because we want to see if the same two-factor structure of descriptive norms and injunctive norms as two separate subscales or concepts will hold in Nigeria and Uganda. And if not, we'll move to exploratory factor analysis. And I would love to share the questions and get feedback. So I just, you know, put them on this PowerPoint slide, but I'm happy to share them. We're still in the process of refining them. So you know, you are the social norms researchers of the field, and I'd be happy to share with anyone who's interested to get your feedback. Next slide, please. So now I'll switch and talk about social norms around self-injection of contraception. So another measure that we're working on in Nigeria and Uganda. So we know from the literature that there's a lot of, that social norms are associated with contraceptive use, but we don't know much about self-injection of contraception. So self-injection is a pretty brand new, it's a novel concept. It was introduced in Nigeria in 2015. So there hasn't been, to our knowledge, there hasn't been any studies or measures around social norms of self-injection. In the US, it was actually just introduced this year. So, you know, Nigeria has 6 years ahead of us. And there's a lot of interest and demand and resources going into understanding how self-injection of contraception use, how it's working, how we can increase use and demand, but social norms haven't been incorporated yet. So we're excited to do that. So as I mentioned, this will be, this new measure of social norms around self-injection. So that's women actually, instead of going to the provider to get self-injection, the provider will, you know, watch her self-inject one time, and then she'll be given 3 other vials to take home so she can self-inject herself every 3 months. So the idea is to kind of increase empowerment and autonomy, demedicalize this, this method of contraception. So the idea is that, this social norms around self-injection of contraception will also go into this cohort study with 1,400 women. And given that self-injection is novel and very few women are actually using it now, we have to have a purposive convenient sample to ensure that we get enough self-injection users. But it'll still be interesting to see, how social norms change over time, and what are the social norms around self-injection in Enugu and Plateau, Nigeria. So our hypotheses we're testing are really that social norms around self-injection will be associated with self-injection among women who expressed interest in self-injection at baseline. And we also hypothesize that social norms around self-injection will become more supportive over time in all three subgroups. So married women, unmarried women, and adolescents. We know from the literature and also from our qualitative research that we've conducted in both countries that social norms around contraception and specifically self-injection are quite different for married women, unmarried women, and adolescents. So we want to ensure that we're measuring social norms, how they differ among all these three different subgroups. Next slide, please. So here's a brief look at our items now. I'd love feedback on these too. So for these statements, we're saying, do you think these statements are true for most, about half, some, few, or none of the people in your community? So we start with descriptive norms. How many married women in your community use Cyanopress to inject themselves? Cyanopress is the brand name of self-injection. And then same for unmarried women and adolescent girls. We're also measuring social sanctions. So we want to know how many people in your community would say negative things about a married woman if she used Cyanopress to inject herself. And we want to understand about the same for adolescent girls and unmarried women. We know from our research, not surprising, that adolescent girls have the biggest barriers to overcome to use contraception in general and specifically self-injection. But given that it can be a more discreet method, there's a lot of potentially promise for adolescent girls or covert users of self-injection. And then lastly, injunctive norms. How many people in your community believe it is acceptable for a married woman to administer the Cyanopress injection to themselves? So it's really just 3 questions with broken down by 3 subgroups. And if there's any other questions or tweaks to these questions, love your feedback or thoughts during Q&A. Next slide, please. So this is just last slide, just our wrap up. So our next steps for social norms around self-injection of contraception are to refine these questions with input from social norms researchers like you and our colleagues on the ground. We plan to pilot test this in Q1 2022, and then administer this. This will be 3 waves of data. Through 2022 through 2023. And then we're going to test these hypotheses and disseminate findings back to the field, hopefully in another conference like this. So our questions for you are really, are we missing important self-injection social norms questions? How can we improve these existing items? And what other hypotheses should we test? We're just kind of in this thought process, and would love to hear from thought leaders like you. I'll stop there and hand it over to the next speaker. Thank you very much for your time, and I look forward to the Q&A.
Thank you very much, Erica, and thanks for keeping to the time frame. We're going to hand over now to the second presenter. Chidera, are you with us?
Yeah, I'm here. Yes, I'm here. Good afternoon.
Okay, over to you, Chidera. Good afternoon.
Okay, thank you very much, everyone. Happy to be here. My name's Chidera Olivia Odani. I'll be taking the topic on knowledge, attitude, and practice towards hospital delivery among women of reproductive age in Paikon Kore, Kagolada, Abuja. Next slide, please. Hello? Next, okay. As a way of introduction, childbirth is a normal phenomenon, and its history dates back to the human creation time and has been along with the evolution of human societies from the traditional to the modern method. This is very important that we understand the factors that come into play during childbirth. So it's expected that women should give birth in health facilities or in the hospital or in the presence of a skilled attendant. But this is not the case, as majority of these childbirths still take place outside of these settings and poses a challenge to combating maternal mortality as a whole. As a way of definition, we should understand that maternal mortality refers to the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration, the site of the pregnancy, or from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. So as of the year 2020, the maternal mortality rate of Nigeria is currently being held at 814 per 100,000 live births. And the lifetime risk of a Nigerian woman dying during pregnancy, childbirth, postpartum, or post-abortion is 1 in 22, which is relatively very high compared to the lifetime risk in developed country, estimated at 1 in 4,900 live births. High maternal mortality poses a major problem to public health in most parts of the developing world, and Nigeria is one of these countries. Next slide, please. The study was carried out in a rural community in Gwagwalada. Gwagwalada is one of the area councils in Abuja. Out of the 6 area councils in Abuja, Gwagwalada is one of them. Paikon Kore is a small community located in Gwagwalada. And this study was a cross-sectional study carried out with a total of 215 women who participated in this study, gave their consent, and data was collected using a interviewer-administered questionnaire. The women that were included in this study included women who have gotten pregnant at least once, despite the outcome of the pregnancy. Next slide, please. Out of the women that were in this study, they were all of reproductive age groups between the ages 15 to 49, and of which 149 were married, and 34 were single, 6 were widowed, 6 were separated, and 18 were cohabiting. Considering the number of pregnancies, 23.7% of these women have been pregnant at least once, 57.2% had between 2 to 4 pregnancies, and 19.1% have been pregnant more than 4 times. From this study, a large number of these women had no formal education, 21.9% of them to be precise, and 33.5% had primary education, while 29.8% had secondary education, and only 14.9% had tertiary education. Majority of these women were housewives and unskilled workers who engaged in petty trading and small-scale farming. In terms of income, most of these women had no steady source of income. 67.4% had a monthly income of less than 30,000 naira, which is below the current minimum wage for Nigeria. And this equates to less than $50 a month. And some of these women had incomes, 16.7% of these women had incomes between 30,000 to 50,000, and only 7.9% had a monthly income of greater than 100,000. Next slide, please. The results of this study, we compared the knowledge, attitude, practice, and we also looked at some complications these women experience because of childbirth. Their knowledge of maternal health services only 57.7% had good knowledge of maternal health services, while 42.3% had bad knowledge. 73.5% had positive attitude towards the utilization of these maternal health services, while 26.5% had negative attitude. In terms of practice, I also looked at the cultural practices that is prevalent in this community, and ritual hot baths seem to stand out with 83.3% of these women still practicing it. Ritual hot bath entails that after delivery, these women are subjected to taking their baths with scorching hot water in the belief that it will cleanse their system of bad blood, in quotes now. After delivery, some consumed the local potash drink. Is a local concoction that they make for these women, and 28.8% of these women still consume this drink. And this is particularly dangerous because it predisposes these women to a certain heart condition, peripartum cardiomyopathy, where these women suffer some form of heart failure. But they are not aware of the possible hazard this can do to their system. This potash drink is mostly prevalent within the Hausa community women, because this community is a mixture of different tribes, you see, but the majority of the women in this community are from the Bwagi community and the Gwari community. The consumption of potash drink was seen more in the Hausa community, the Hausa women. 11.1% of these women had no birth attendant present at their delivery. So while we have 73% of these women attending the antenatal clinics, going for their checkup, majority of them still, or rather a large number of them still give birth at home in the absence of a skilled attendant, and this predisposes them to coming down with complications later. 59.5% had skilled birth attendants present at their delivery. So some of them make use of midwives at their delivery. Some because these midwives are part of their communities, there are people that they are familiar with. So some women make prior arrangements with these midwives to help them with their delivery. Care of the cord. 34.8% of these women still use toothpaste to care for the cord, while 0.3% use cow dung to care for the cord of their babies, and only 24.7% of these women use methylated spirit. This is to say that there's a lot of influence of a lot of cultural influence that push these women to making these decisions, because when I ask them their reasons for using such, they keep saying that it's something that has always been done. Their mother told them, their mother-in-law told them. So you see that this practice is a cultural thing. It's something that has been going on for years. 53.0% commenced breastfeeding within 24 hours. The others that didn't commence breastfeeding on time, they usually feed their babies with glucose water, or they mix water and sugar to feed their babies within this period before they commence breastfeeding. In terms of complication, perineal tear, foul-smelling discharge, and prolonged labor were the 3 complications that had the highest prevalence within these women. Next slide, please. From this study, it's noticed that from this study and from similar studies done in other parts of Africa, there's a similarity where the mean ages from this study being 27.9 and that in Ethiopia being 26 plus or minus 2. In terms of knowledge, this study had 57.7% had good knowledge, while a study done in Ethiopia, 72.4% had good knowledge. The presence of, while in northern Bangladesh, only 25.6% had good knowledge of maternal health services. So this is to say that both in Africa, Middle East, and in Asia, a similar result is gotten from studies done within these areas. In terms of attitude, only 73.5% had good attitude from this study. And in rural Pakistan, 69.6% had good positive attitude, while 61.2% had positive attitude in a study done in Ethiopia. Next slide, please. Although there is a high percentage of these women who go for antenatal clinic, a large number of them still opt for home delivery. This could be due to low financial support, cultural beliefs, and some see it as a natural process that doesn't need the presence of a skilled birth attendant. There are several factors that influence the maternal health service utilization, and they operate at various levels, both individual, household level, community level, and state level. Study shows that the cultural belief and norms have an influence on maternal health services. Recommendations to improve our utilization of maternal health services include to increase awareness via health promotion activities and reinforce need for appropriate and adequate antenatal care, advocacy by the healthcare personnel to community leaders on the importance of allowing women to make decisions about when and where to seek help in the absence of their spouse, improve quality of care at the health facilities, education of the girl child, and discouraging child marriages and women empowerment. Since the traditional birth attendants are necessary for reasons of acceptability, adaptability, and accessibility, their skills should be upgraded by mounting refresher courses, which will be overseen by healthcare personnel. This will enable these women to be able to assist pregnant women in delivery, but doing so in the right way, and also equipping them with supplies. Maternal healthcare services should be heavily subsidized to encourage this population group, which has high mortality and morbidity, especially in sub-Saharan Africa. This will increase utilization of and their chances of survival. Next slide, please. Thank you very much for your time.
Thank you very much, Chidera. Interesting findings from your study. I think it reinforces a lot of the norms that we know that continue to hamper maternal health in Nigeria, especially in the northern parts of the country. I'm hoping that there are questions and comments from people on the call. We're not going to be able to do the third one because unfortunately, Emily had a family emergency she needed to attend to. And so we will have time for more questions. So we will head straight to the Q&A now. I am not seeing any questions here for Chidera yet. So I was wondering if Erica had some feedback that she wanted to give in response to the questions that have come in so far. Erica? Erica, are you with us? I know we've been
I am here. Yeah, I just the host needed to unmute me. But thank you for unmuting me, host. Yeah, I thank you for the feedback in the chat. This was exactly what I was hoping to get. Some really great suggestions on looking at covert use, and so actually looking at social norms around covert use. And then as Betsy suggested, looking at the difference around social norms between newly married women and women who already have one child is also, a great suggestion. Yeah, so I think these are really good suggestions. I hope we have enough space to include, social norms around women who are trying to use self-injection if they don't have their husband's permission or if they're covertly using. The other thing that it made me think about also is we found in our qualitative research that some providers are actually asking women if they have their husband's permission before they give them Cyanopress, which is unfortunate because that's definitely not necessary, but part of the social norms around contraceptive use for women in general. So, that's something we might also want to inquire about. But I'll open it up if anyone has any other suggestions or thoughts on this work. It sounds like even from some direct messages, some of you are working in this field, so I'd love to hear more thoughts if you have them.
Feel free to also raise your hands if you would prefer to speak rather than using the chat. I have a question for Chidera from my end. I wondered because in our work, we find that these issues are typically linked with different archetypes of women. So I wondered if you were able to draw any connections between specific socio-demographic factors for these women. So you mentioned or you categorized the women based on their parity, that is how many children they have, the income levels, the education levels, and all of that. And I wondered if your findings were in keeping that lower income or higher income, how bad is the knowledge and attitude or practice towards maternal delivery at the hospital. Specifically, I'm wondering about parity because we find that maybe in the younger ages or women who are at their first, who are having their first child may not have the same level of experience as the older women. So were you able to draw any comparisons between the groups of women versus their outcomes or their attitudes and knowledge to delivering in the hospital? A second question is really if you could define the difference or what you meant by bad knowledge and negative attitude, just to be a bit more clear on, what those metrics are. Over. Chidera, if you could respond to that before we go to the next question that someone has just dropped in the chat. Is Chidera with us? Chidera, if you are speaking, you're on mute.
We may have lost her.
I'm not seeing her currently. Sorry for that.
Oh. All right then. Are there any questions or comments for the first presenter on norms? If you look at the chat, Erica, you would find someone is also suggesting to look at provider norms about self-injection.
Yeah, that's a really great point. And I think we should do that because as we know, providers, and from the literature, providers have, our questions are just for women of reproductive age, but we can ask them about their experiences with providers, specifically for women who are using injectables or self-injection. A lot of the research from PMA on self-injection is saying that even within the possibility of self-injection, most women are still opting to have their provider actually administer it. So it's really provider administered injections. But so I think, yeah, that whole piece around provider communication and norms. We've also seen some data around providers wanting to give it, as I mentioned, to married women only or to more educated women. The feeling that married, older, more educated women would have the better capacity to do it, which is also not a requirement. So we want to understand those norms around education, marriage, and provider bias. So thanks for that point. It seems like I've got a lot more questions to add if we have the space.
Yes, welcome back, Chidera. We'll come back to your questions shortly. Beatrice had a comment. Beatrice, could you unmute your mic and speak?
Thank you very much. I was just going to address Chidera's presentation. This survey took place in Gwagwalada Area Council, and Gwagwalada, to me, appears to be an urban local government with the University of Abuja Teaching Hospital available. And it seems that there's a higher level of education also there. I was wondering if it were possible to do a similar thing in a more rural LGA to see what we can get, so that we have an idea what is happening, because we have just from her presentation put the result of this survey side by side with those from other countries. I thought that it would be interesting to know what is happening, whether it's the same situation in the rural areas. And if there's a possibility to also conduct a similar survey in an LGA that is a bit rural. That's just my comment. Thank you
very much. Yeah, thanks, Beatrice. I think that's very important. Comparing with other countries is great. Comparing with, and I think I'm just trying to link this to my question, which is also comparing within the groups that we've discussed. Chidera, are you able to shed more light on what the interconnections are? So parity especially, as well as income and level of education, what were the differences in the knowledge, attitude, and practices that we saw? So that would be a second question. And the third would be, if you could just clarify what you meant by bad knowledge and negative attitude.
Okay.
If you answer those, we'll answer the next set shortly after.
Okay. Although Gwagwalada Area Council has the teaching hospital there, it has the university there, it's a very big local government. And within Gwagwalada, you still find very rural communities there. So the study was in one of those rural communities there. Although they have access to the teaching hospital, they have access to, there's a town's clinic that's very close to the community. I still got these values, these results from this study. So that goes a long way to show that although these facilities, it's at their doorstep, they are not utilizing it to its full capacity. I don't know if that answers your question. Then in terms of their social demography, for women that got, I noticed that these women all got married or had their first pregnancies at a very young age, from 16 years of age. Some of them already had their first child or 2 children at that age. Education played a lot of role in determining where these women gave birth, because those with no formal education tend to give birth at home in the presence of an unskilled birth attendant or by themselves. There were about 4 or 5 women that gave birth on their own, they saw it as a normal thing. They didn't need to have the presence of anybody to assist them. There's this social gratification of, oh, I gave birth by myself, I'm a strong woman. Then there was the issue of poverty among these women in this community. A lot of them are housewives, a lot of them are unskilled. They just stay at home, take care of the kids, while the men engage mostly in farming too, or small scale trade, selling firewood and things like that. Then someone asked about what I meant by good knowledge, bad knowledge. Good knowledge in terms of, okay, they have good knowledge in respect to the presence of maternal health services, that is antenatal care, postnatal care, if they are aware about it, what it entails, what happens when they go to antenatal clinic, if they know all these things. And also the bad knowledge means they don't have any idea what's going on there. In terms of attitude, positive attitude, those that were open to using these healthcare facilities and those that were not, that didn't want to make use of them. That's what I meant by good knowledge, bad knowledge, positive attitude, negative attitude. I hope that answers the question.
Yes, Chidera, thank you. I think we have 2 more questions that you can quickly respond to before we go on a short break. So the first one is, are there critical gender issues you want to itemize in the presentation? And the second one is, can you talk more on how to address the issue of home delivery?
Okay.
So are there gender issues you want to itemize? And then are there ways that we can address home delivery based on your findings?
Okay, gender issues from this study had to do with the education aspect. Most of these women were not educated up to the tertiary level. Most of these women got married at a very young age, and these women were not engaged in any form of occupation. Most of them were housewives. Then the issue of, okay, although it wasn't part of the scope of my study, these women were not open to using, for my interactions with these women, they were not open to using contraceptives in any way. They deemed it being bad. And when you ask, they always say they said it's not good. Somebody said it's not good, but there was no critical reason for their reason for not using contraceptives. Then on the issue of how to address home deliveries, from my presentation, I suggested that since these women make use of the traditional birth attendants to take their deliveries based on the reason of acceptability, adaptability, and accessibility, that these traditional birth attendants should somehow be incorporated into the system for these reasons, so that since these most of these women in the rural settings prefer the services of those traditional birth attendants, these attendants should be provided with supplies to ensure that the deliveries of their babies are done in the right way to minimize infection, to minimize maternal mortality and morbidity. Also, the women should be, the advocates, the community leaders should be educated on the importance of allowing these women to decide when and where to seek help. If it is the home delivery that they prefer, they should be provided with the help of the skilled attendant, maybe a midwife, come and assist them in delivery. And this midwife should be able to refer in cases of complications to reduce the risk of any morbidity or harm to the women. I hope this answers the question.
Yes, Chidera, it does. Thank you very much for responding to those questions. In the absence of any other questions, I think we can continue the conversations in the chat, and I will hand over back to the overall facilitator. Over from me, and thank you for this very interesting session we just had.
Thank you, Raina, for moderating that session. I think we can now, we'll now be going on a break for just to catch up on time. So we'll be back from our break at about 5 minutes past 3. And once we come back from the break, we'll be going straight into the next section, which will be moderated by Dr. Mohammed Liman. So thank you, everyone. See you in by 5 minutes past 3 p.m. Someone, can you hear me?
Yes, we can.
Okay, great, thank you. I had a bit of an internet challenge. So welcome back, everyone. Jumping straight into our next section, we'll be having, the next section is themed responsive feedback, and it'll be moderated by Dr. Mohammed Liman, who is the research director of the COV Development Outcome and Support Center. So Dr. Liman, over to you. Dr. Liman?
Hi, sorry, I was unable to unmute. Thank you. Hello, everyone. Can you hear me?
Yes, we can hear you.
Thank you. So my name is Dr. Mohammed Liman. I work with the Development Outcomes as the Research Director for the CAF. And I would like to welcome all participants to this session. The subtheme for this session is responsive feedback, the 5 steps to get better, faster in social norms program. Just to give highlights on the subtheme, we know that the current dominant models of intervention design in the development sector do not account for the complexity or unpredictability of program implementation challenges. Therefore, decision makers and implementers that need timely feedback during implementation are unable to respond to field realities in a timely fashion. And they are also not able to course correct while the program is live in the field. So this calls for a new approach of responsive feedback, or feedback loops, as it's known in other quarters, that promotes interactions between project designers, implementers, researchers, and decision makers to enable us course corrections needed to achieve intended outcomes of our various programs and projects. So in this session, we'll be listening to 3 speakers discussing responsive feedback and its application. The first speaker, which coincidentally happens to be myself, will take you through the meaning of responsive feedback and introduce you to the 5-step process for embedding responsive feedback to get better and faster results in social norms programs. While the second speaker is Bolaji Oladejo, State Program Manager with Society for Family Health. Bolaji will be taking us through a case study to show how Integrate E project, which aimed at increasing uptake of family planning services, applied the 5-step process of responsive feedback to uncover a difference in social norms between 2 implementing states in Nigeria. The third speaker is Onyekachi Ewe, who is a demand generation technical service lead with the Challenge Initiative in Anambra State. Onyekachi will share the Anambra experience using notable local event tagged Annual Women's August Meeting to change social norms in favor of family planning in Nigeria, specifically in Anambra State. I hope you will enjoy this very interesting and promising session as we look forward to your active participation during the question and answer period that will come after the session's presentations. We have, for the presentations, total of 25 minutes. The first 2 speakers will take 10 minutes each, while Onyekachi, the third speaker, will take 15 minutes. So I hope we will stick to the time as we progress. I welcome all participants to this session once more. And we are good to start, and I will start. So responsive feedback, the 5 steps to get better, faster in social norms programs. In particular, we are advocating for a specific framework or approach for integrating learning through responsive feedback. As you will see, this is a presentation that's had a broad framework that can be leveraged by programs and projects to uncover, adapt, and respond to social norms as a program is live in the field. Next slide, please. The curve believes that if we keep learning, we keep moving, and we keep improving, catalyzing our impact, delivering better program results. And to showcase this, we have a short film to show you. Come up the next slide. That has film, please.
Here's a simple truth. If we keep learning, we keep moving forward. Only faster. You see, ongoing learning is a shortcut. Examine how you think your programs work right from the start. Where are the blind spots and assumptions? Then seek feedback that can shed light on these. Don't wait for problems. Ask questions. Act on answers. They say hindsight is a wonderful thing, but foresight is a million times better. Data can reveal what we can do better, not just how we've done. So keep asking questions. Keep listening to answers. Keep testing new ideas, not just at the beginning, but throughout. We call this responsive feedback. How can you get started? We are here to make it easy, with step-by-step guides and advice to help you put theory into practice. So if you want to get better faster, the place to learn is here.
Thank you. So having said that, let's ask ourselves, who are the curve? Next slide. So the COP is a consortium comprised of 3 organizations: the Harvard T.H. Chan School of Public Health, M&C Saatchi, and Development Outcomes and Support Center. We've been working together since 2018 to encourage programs to learn through responsive feedback. The role of the consortium is to convene the community of practice and ensure that the right people with the right skills, resources, and motivation are involved, and also that such people connect through the community of practice with global best practices, getting advice from the development partners, from the academia and the private sector to inspire and enable them to improve their programs. Next slide, please. Our community of practice is a global community and includes all organizations that you see on this screen. In Nigeria, members of our community of practice range from the executive secretaries of states' primary healthcare development boards to country directors of international organizations and leading program officers at leading donor organizations. Next slide, please. Our mission is to democratize responsive feedback. We want to make it easier for all grantees in Nigeria to embed learning through their programs, particularly as we look to this being a future requirement in all BMGF grants. Next slide, please. So to help you do this, the COP runs a series of activities, which include convening the community of practice in plenary learning sessions to share best practices and guides, conducting responsive feedback trainings, and developing pragmatic written guidance on key themes and approaches. The CAF also delivers technical assistance to organizations to embed responsive feedback. We also promote and advocate responsive feedback to key stakeholders and thought leaders throughout the country. Next slide, please. So before we tell you more about those, we want to dive a bit deeper into responsive feedback. So what's responsive feedback? Technically speaking, responsive feedback is an integrated framework that incorporates elements of feedback, continuous learning, and engagement. Responsive feedback is the belief that foresight is better than hindsight. learning how we might do better before there's a problem, learning about how to enhance our performance before a program comes to an end, and using feedback to learn now so we can adjust now while the program is live. Next slide, please. Of course, we recognize there are similar approaches such as the adaptive management, feedback loops, or mechanisms, rapid cycle innovations, which have been developed out of dissatisfaction with traditional intervention designs. The area of approach is similar, but also builds on these models. Next slide, please. There are many benefits of responsive feedback, which we can see here. I don't need to go through. A few of them is that we get more value from data when we use responsive feedback, and we make decisions with greater confidence so that our programs can get better and faster. Next slide, please. So briefly, this is the 5-step process for proactive learning through responsive feedback, which we'll see in more detail in the next presentation. So it's an acronym. C stands for convening stakeholders, U is uncovering assumptions, R is revealing learning opportunities, V is seeking evidence, and E is evolve. So we will have in the next presentation a detailed application of this 5-step approach. And I will pause at this point for the next presentation to be given by Bolaji Oladejo, the State Program Manager for Society for Family Health. Bolaji, over to you, please.
Okay. Thank you very much, Dr. Lima. Good afternoon, everyone. Just like Dr. Lima said, my name is Bolaji Oladejo. I'm the State Program Manager for Integrating Projects in Lagos. And I'll be presenting this afternoon on how we use responsive feedback to adapt our social norms in Lagos and Kaduna State. I'll be using a case study of Integrate E-Projects. Integrate E-Project is a family planning project that is being implemented by Society for Family Health and a consortium of other partners in Lagos and Kaduna State. It's a proof of concept project that is working with community pharmacists and patent and proprietary medicine vendors, call them PPMVs, to increase access to family planning services in Lagos State. So basically, the aim of Integrate E-Project is just to increase uptake of family planning across Lagos and Kaduna State in Nigeria. And like I said, I'll be presenting on how we use responsive feedback to uncover a difference in the social norms between these two implementation states of Kaduna and Lagos. And this actually allowed us to adapt our project demand generation strategy in order to adapt to the social norms and also increase significantly the effectiveness of the project. So we'll be looking at how we use the 5 steps of responsive feedback to adapt to social norms. Next slide, please. Next slide, please. Okay, thank you. Yeah, the first step talks about convening stakeholders. And the first thing we did was to map our stakeholders. It's very important to map all the stakeholders so we can get their buy-in and use this feedback to create working together to also get a responsive feedback during the process of implementation. So the key stakeholders that we actually identified included the SFH program staff, of course. We have the program staff, the monitoring and evaluation staff. We have government officials from the Federal Ministry of Health, the State Ministry of Health, the Pharmacist Council of Nigeria, and of course the providers, the trained providers, as the community pharmacists and PPMVs that we train. And this helped us because we initially engaged them so that they're involved in the program design from the onset. And this actually ensured that we have their early buy-in, and that's helped for continuous learning and for responsive feedback. Like I said, the responsive feedback actually helped us to reduce barriers to implementation throughout the course of the program. Yeah, you can see from the picture actually consisted of all the stakeholders from the Federal Ministry of Health, State Ministry of Health, the providers, and of course the program implementing team. Next slide, please. Now, the second step is to uncover assumptions. The project theory of change assumed that the most effective method for demand generation for family planning in both Lagos and Kaduna states would be to have one-on-one interpersonal communication for demand generation using the IPCAs for mobilization and for referrals. So it was actually, this assumption was based on the fact that one-on-one IPC strategy provides confidentiality and privacy that are needed in family planning services. However, the data that we actually got showed that this strategy was very effective in Kaduna. However, in Lagos, it was not that effective because we saw the increase in uptake in both mobilization data and family planning uptake in Kaduna State, while the reverse was the case in Lagos State. And this shows that, and from this, we actually looked at, okay, what are the gaps that we have in our assumption? And this gap really helped us. Okay, we say, okay, if these are the gaps that we have been able to identify, can we see how we can use this? We can translate this to knowledge and use these assumptions, use this gap to change, to know the next step the next step of action, so as to be able to change our theory of change and make our assumptions explicit. So because of this, we'll go, and in the course of this, we'll go to the third step that talks about revealing learning opportunities. You reveal learning opportunities. Next slide, please. Okay. Now, the translation of assumption in this next step, you translate assumption and knowledge gap into learning questions. Like I said earlier, our assumption was that one-on-one IPC strategy will be very effective in both implementation states of Kaduna and Lagos State, based on the premise that it offers confidentiality and privacy. And we realized that this only worked for Kaduna and not Lagos. So we said, okay, what are the learning questions that we can derive from this? And we're able to derive two key learning questions. The first one is, where social norms are around family planning in Lagos and Kaduna State the same or different? And we saw that from the pictures. You see, the picture to your left depicts, this is actually a picture from Kaduna State. So you see that the situation in Kaduna is different from that of Lagos State, which is in the other picture to the right. There are some things that actually affect the social norms, the religion, the culture. So the culture in Kaduna State is different from that of cosmopolitan city of Lagos. In Kaduna State, because women are more reserved in Kaduna than in Lagos, and they are not very open, to discussing family planning like that. So they prefer to have one-on-one discussion with IPCAs, unlike in what happens in Lagos, where everyone is busy. Nobody cares. If you meet them on the road, they might not even answer you. And that's the situation we had in Lagos State when we're using one-on-one IPC strategy. But when you have people gathered together, people are inquisitive, they want to know what is happening. And this really helped us to see that the social norms around family planning in Lagos and Kaduna State, they are not the same, they are different. And the second learning question is that should there be implementation approach? Should our implementation approach be adjusted according to these different social norms? So that was the second question. And the answer to this is yes. We realize that since the social norms in the two states are different, that we had to change our implementation strategy in the two states. Now, the next step is to seek evidence, finding the evidence to answer our questions. And to answer this question, what we did was to conduct stakeholders meetings. So we went to the different stakeholders that we have been able to identify. So we used, we met with the IPCAs themselves, the government officials, of course, the providers and community members that we actually serve. You see the two pictures. We saw the first picture showed what the community dialogue we had with the providers in the community, the providers and some of the beneficiaries in the community members rather, were also part of this review of this community dialogue. And the second picture shows the the review meeting we had with the IPCA to actually in Lagos State to actually identify what were the reasons behind the low mobilization we're experiencing in Lagos and the low FP data, the FP uptake in Lagos State. So we gathered, we actually sought for this evidence using different avenues such as the community dialogue, the IPCA review meeting, providers review meeting to engage all the necessary stakeholders to be able to gather evidence that we'll use to change our demand generation strategy. Next slide, please. Now, after this, the next thing is to evolve. You pause and reflect. You arrive at distinct lessons and an action plan. So based on the feedback we got from the stakeholders, it shows that the assumption that one-on-one session will prove effective was true in Kaduna. Like I said, women are more reserved in Kaduna. They love that privacy. They would love to discuss family planning one-on-one, especially with a female also. So we tend to use more of female IPCAs in Kaduna State and with one-on-one, using the one-on-one IPC strategy. While in Lagos State, in Lagos State, people were not getting, the IPCAs were not getting attention of, you know, the people in the community because they feel they're not disposed to somebody just accosting them on the road and telling them about family planning. But we realized that, okay, we can change our strategy from one-on-one IPCA to group IPCA strategy in Lagos State to be more effective. And that was what we did. So we got that feedback and changed to group IPC. You can see when we have, in this picture, we have two IPC, one with jacket, the other one wearing white, talking to a group of women that have been mobilized by them in the community. And this, when we have group IPC conducted, it gives the IPC opportunity to also conduct what we call the pre-mobilization advocacy in the community. So they inform the community leaders, which are part of our stakeholders. And these community leaders would have actually told the people in the community, would have informed them that the IPCAs are coming. So they are more disposed to seeing the IPCAs coming in group. And as the IPCA mobilize them, they don't just issue referral cards to say, oh, go and uptake your method with a CP or with a PPMVs. We have another IPCA that takes them to the provider. So we're having accompanied referral, and this really helped us. So group IPCA, we changed from one-on-one IPCA to group IPCA in Lagos, which really helped us. Next slide, please. Now, what's the result that we got from this, from responsive feedback that helped us to change strategy? We can see that within 3 quarters, our mobilization and redeemed referral figure increased significantly by 32%. So mobilization figure increased by 32% within 3 quarters, while the redeemed referral increased by 184% in Lagos State. Now, we didn't need to change strategy in Kaduna because one-on-one IPC was working, but in Lagos State, based on responsive feedback, we changed our strategy from one-on-one IPCA to group IPCA, and we can see the results. Within 3 quarters, we had both mobilization figure and redeemed referral for service uptake has increased in Lagos State. Next slide, please. Okay, I think that's the end. It's just to show us the process, how we have used responsive feedback to adapt to social norms in Lagos and Kaduna State, and how this has helped us to be able to improve on our program implementation. Thank you.
Thank you very much, Bolaji. May I invite the third speaker, Onyekachi Ewe. While waiting for Onyekachi, please let me remind all participants to either drop your questions or comments on the chat box, or you keep them until the period of the question and answer sessions.
Good afternoon.
Over to you. Go ahead, Onyekachi.
All right. My name is Onyekachi Ewe. I'm the technical support lead for demand generation for the Challenge Initiative. I'll be taking us through a presentation titled Using Notable Annual August. While we wait for the slides to come up, using notable local events, that's the annual Women's August meeting, to change social norms in favor of family planning in Nigeria. And I'll be sharing the Anambra experience. I'm making this presentation on behalf of my co-authors, Anota Egbe and Folusho Emmanuel. Next slide, please. So it's no longer news that in the month of August in the Southeast, which Anambra State is one of the states in the southeastern part of Nigeria, the women hold an annual August meeting. Now, for those who are not very conversant with what this meeting is about, let me give a background. The August meeting is an annual congress held by the Igbo women in the month of August. Now, it's a massive homecoming of women, both home and in diaspora. When I say in diaspora, those living outside their states, whether they're living in another state in Nigeria or even outside the country, they all converge in their matrimonial villages to discuss matters pertaining to community development, conflict resolution, I beg your pardon, and also to come up with socioeconomic and cultural initiative. Now it cuts across. Every woman can participate. The criteria for participation is that you're a woman in a legally recognized union. By that I mean, once the woman is married, she can participate, and it's held at the church level, so giving leverage to those who will partake in it from the religious angle, and also those who will partake in the traditional aspect who may not be Christians, although people in the Southeast are predominantly Christian, but for those who are traditionalists, there's also the meeting held at the community level. So it's a huge forum, and it's a forum that we can use, we leveraged to reach women of reproductive target audience for family planning, to change their social norms in favor of family planning, and also their influencers, the elderly women, the mothers and mother-in-laws. So let me give you a brief of the Challenge Initiative. We are an urban reproductive health platform, and we support state governments, of which Anambra State is one of those states, to implement innovative family planning approaches that will gradually shift the social norms in these states in favor of FP. TCI supported the state government and other key stakeholders to leverage this notable event to mobilize more women for family planning services, and the discussions that take place at these mobilization events gradually created a shift in social norms in favor of FP, which we would see in how they began to respond in terms of visiting the facility for counseling and service delivery uptake. Next slide, please. So TCI, we provide intensive coaching and mentoring, technical assistance to the state government for them to now be in the driver's seat and provide direct implementation to the LGAs and communities. The first thing we did was to set up a state social and behavior change communication technical working group, so that they can coordinate all SBC interventions in the state, which includes awareness creation and mobilization for family planning services. Now, in the first year, we provided, we led the CWG to create demand for health services, including family planning services. And in the second year, we made them, we ensured they were in the driver's seats. Everyone is looking at sustainability, institutionalization of implementations in the states, so that even when donor funds or partners are not around, the states can self-sustain. So they were in the driver's seat while we provided assistance in terms of capacity building, supportive supervision. And in the third year, now we are observing them while they do this implementation with just a light touch of coaching. So we call this a lead, assist, and observe coaching methodology or model. And with this, we have built the capacity of the SBCTWG to facilitate program implementation. So we helped them to identify this notable platform, the August meeting platform, which is an annual event. And they began to provide social mobilization services, actively creating awareness during this meeting for family planning services uptake. Now in 2021, we added something extra. In the first 2 years, we did a wide campaign sensitizing the women during their meetings. But in this 2021, during the August meeting, we added a health facility in which the mobilization was now accompanied by direct service delivery. So for any woman who is interested in taking up family, who is willing, and they're willing an intender that wants to take up family planning services, they were referred immediately where a provider was waiting at the health facility for them to take up family planning services. Next slide, please. Next slide, please. Thank you. Okay, so this shows pictures of some of the August Women meeting where members, executives from the SBCCTWG are with the women, and also in another picture in another community where members of the SBCCTWG are sensitizing the women of Isulo community in Anambra State during their August meeting. Next slide. So we can see that the data set for 3 years, 2019, 2020, 2021, showing 3 months, that's July, August, September, and showing number of women reached, number referred, and number completing referrals, shows that in August, the data spiked. We had the highest number of women reached in August, which is attributed to the contributions from this August meeting sensitization. For number of women referred and number completing referrals, we can see that in August we had a higher number, and in 2020, despite COVID, a lot of the meetings were not held because that was the peak of social distancing and trying to really uncover what COVID was all about. We saw that more women accessed services even in the following month in August, and then as a result of this sensitization, creating that enabling environment for them to access services, they accessed in the following month, which is September. And we can also see the data for demand generation in these 3 years in 2019, 2020, and 2021. All right, next slide, please. This is also service uptake across the LGAs. We can see that in August, for the 3 years, service uptake increased and also continued to increase in 2019. But in 2020 and 2021, we have the highest service uptake in the month of August, which is also attributed to this notable platform because of the huge attendance of women from all walks of life and also the active sensitization during this event. And it has proven to actually be cost effective because it's just leveraged. We leverage the existing platform, the indigenous event, to reach them with family planning health messages. All right, next slide, please. So conclusively, I'll just say that a local event such as this notable annual August meeting has proven to be a useful platform in changing social norms Now, this is a gathering of women, like peer to peer. They can bare their hearts in terms of discussing the myths and misconceptions they have about family planning without fear of discrimination. Yes, I found the presentation by Erica rather interesting, the first presenter in today's conference, where she was talking about how these social norms are measured. We know that there's already a huge gap in our gender balance, and when women are in the same environment with men and you're talking about reproductive health issues, most times women do not speak up. If they must speak up, they'll come to you one-on-one to have their doubts clarified. And that's for the ones who want to really take it a step further. But for the ones that are very reserved and they may not get the information in such gatherings where the genders are mixed. But in this platform where it's all women, you see women opening up, making discussions, and their myths and misconceptions prevailing in the community are corrected, dispelled, the rumors are dispelled, and you see a quick uptake because their knowledge is being changed in that gathering. Now, women can also freely discuss issues around FP with their peers. Yes, that's what I was just trying to say, in these community meetings, and also in, now they're beginning to discuss also freely in larger gatherings and even to a wider audience through various channels like the radio and television without fear of sanctions or discrimination. We have seen the data set for these years, and it's a clear evidence that the social norms are gradually changing when it comes to family planning through this platform. And like I mentioned earlier, it is cost effective. So institutions, program managers, implementing partners should begin to look at adopting this approach for integrated health programs, especially in the southeastern states, where this meeting is built to hold in August of every year. All right, so thank you very much. That will be all from me for now.
Thank you very much, Oyakachi. So we are now on for the questions and answer session. And we've got a lot of questions on the chat box. So if you have more questions, please either indicate by raising your hand or continue to place them on the chat box. And I have a few here which I'll read out. So the first question came from Ijeoma. Ijeoma was asking whether what was the selection process of stakeholders in the COF. And I think looking at the chat box, Tom had already responded to her. He has tried to explain that the COF works with the local convening partners to identify the key stakeholders, focusing on government partners, donors, as well as medium and large size programs across the BMGF priority areas. And that had motivated and built capacity to engage. So I think that was a response. And then additionally, there was a question also from Ijeoma asking about from Hadiza Umar, asking whether we include civil society organizations and groups, especially those involved in accountability in our fund. And again, yes, Tom responded to that in the affirmative. So we do engage the civil society organizations in the community of practice and other supports. Another question, I think this is for Bolaji now. did the change require a modification of the theory of change? And if it did, what was the donor reaction? So that question is to Bolaji. And then, yes, again, I have a question also, especially around the resources that are required to embed responsive feedback. Must you get additional resources outside your budget for you to effectively implement responsive feedback? As this has come up after already you have either designed your program or you've already gone mid in the implementation. So will you require a lot of resources that will really be a challenge for you to embed responsive feedback? And there was a comment also for you, Bolaji, from Ellis. She said that's really a very clear case study. Thank you. So maybe you can answer that before we go to the questions for Onyekachi.
All right, thank you, Dr. Lima. Thank you everyone for the questions. The first one talks about modification of theory of change. Yes, it required a modification of theory of change. But one thing that we did at the onset was to build some level of flexibility into our programming. So we already got some of these things were discussed with the donors, and we're having regular feedback meetings with our donor. We don't wait until we do our quarterly report. We have like a monthly check-in meeting with our donors, so where we give them some of these feedback and seek for approval to change strategy. The good thing is that the strategy, that the modification that we did based on responsive feedback to change our strategy did not require us having additional resources. We just made use of what the available resources. So all we needed to do was to change strategy. So the number of IPCAs that we're using did not increase. We didn't incur extra costs. In fact, what we only needed to do, some of these meetings are part of what we built into the program, providers review meeting, IPCA review meetings, then community dialogue. They are part of what we built into the program. So we just needed to give them this feedback during some of these meetings, and we went back to the donors to say, oh, this is the feedback we're getting from our review meetings, and we feel that we need to change our strategy. And the donor gave us a note, since we didn't require additional budget, so we didn't need additional resources, and of course we built flexibility into our project from the onset. Let me also say that this is actually a proof of concept and PPMVs to strategy as long as that will actually give us an improved performance in our implementation. I hope I've answered the questions.
Yeah, thank you very much, Bolaji, for that. So let's move on to Onyekachi. You have a few questions also, but I have one or two for you before we look at what others are saying. Did you encounter any misconceptions while engaging with the community groups? Misconceptions or political interference or whatever, working with us, because we are working with varied interest groups within communities?
There are already prevailing misconceptions in Anambra State when it comes to family planning. And we have continued to use our platform to try to address these misconceptions. So there are a whole lot of them. I don't know if you want them mentioned or.
Okay, that's fine. How were you able to manage that, especially getting the feedbacks and taking action immediately using the responsive feedback mechanism?
Now, we use multifaceted approaches in handling these misconceptions. Number one, most of these misconceptions stem from the fact that these people do not have a clear understanding of how family planning works, the benefits, and even the correct places to access this family planning method. So it's all, the misconceptions are all based on hearsay. So when you bring experts to them to tell them about the various methods, the benefits, go further even to explain the mechanisms and where they can get the methods and get proper counseling, you see them begin to respond positively. There are also instances where we use satisfied users, people who have adopted a method and probably even discontinued, and they conceived when they wanted to, because we always emphasize that this is not just about child limiting, which is the mindset of a lot of women. I'll have all the number of children I want, then I contracept. It's also about child spacing, giving that space within intervals, 2 to 3 years within each pregnancy, so that the woman can recover and be healthy and also have healthy babies. So by the time they hear these things and they become very excited, they embrace eye-opening for them, and it prompts them to take action to adopt a method. Yes.
Okay, thank you very much. This is a comment saying thank you for the beautiful presentation. I think that's from, can't get the name again. One more question for you, Onyekachi. Apart from the capacity building, were there other incentive mechanisms that you introduced?
Capacity building for the SBCC-TWG?
Yes. I mean, other incentives for the women groups, especially.
Oh, no. For those women groups, the main thing that was, these are existing platforms that their members are the ones, most times the SBCC-TWG member is also from that community. So access to that women group is almost like seamless. It's like, I'm bringing in, this is my contribution for the August meeting. I'm going to bring experts that are going to talk to us about benefits of family planning. So what we come with is the message and SBCC materials to further engage them in the discussions. No extra incentives.
Okay, thank you very much. I think
I can see 2 questions in the comment box. Can I address them?
Yeah, go ahead and address them.
Okay, the first one says that, is there a community event where unmarried women are also informed about this family planning messages? And I will say yes. The August meeting is designed for married women, but in the support and technical assistance we're providing to the state, we also map out secondary and tertiary institutions, vocational institutions. We have same-sex schools where we sensitize the senior secondary students on their reproductive health with adolescents and with AYISRH messages, adolescent and youth sexual reproductive health messages. We have same-sex vocational institutions where we leverage special international days like International Youth Day or International Day of the Girl Child. We sensitize these young women or married women on family planning messages and how they can make informed choices when it comes to their life planning. Then the second one says, are there FP initiatives directed at men? What was the uptake in those instances? Yes, we know that the man in this part of the country is the head of the home, and for a woman to freely adopt family planning service, then there should be an enabling environment. There should be that social support coming from her spouse. So we also identify men as key target audience, and we reach out to them in male involvement sessions, in their vocation, in their groups, where their age grade groups, their associations and all of that. But because of the relevance of August's meeting to this conference, we showcased the data where we've been reaching out to women using this platform. We also have initiatives targeted at men. I hope that addresses the two questions. Thank you.
Yeah, thank you very much.
Okay, thank you so much. I think we can move now on to our next session. So we have a number of people who are going to be speaking during our faith-based session, and I will begin unmuting you all now. We're just doing manual unmuting just to make sure the sound is under control for all of the conference.
Okay, thank you very much. So I think we will pause here. Please feel free to contact the speakers individually. There were two more questions that were on the chat box, I think for Onyekachi. So I will refer you to Onyekachi to further pick up with her individually. But on this note, I would like to thank everyone for your active participation in the session. And it's my pleasure to introduce to you the next moderator, Luke Martin, who is the SGV program officer, who will be moderating the session on this next sub-theme. So thank you very much and have a wonderful day. Thank you.
Great, thank you. And what a wonderful presentation that was just before us. So thank you for that. Is it okay to have the slides shared, please? Thank you. So I have been asked to host this session, which I feel very privileged to do. So my name is Luke and I work for Tearfund and I am based in the UK. And I have supported the programme from the UK, but I very much recognise that the vast majority of this programme was led completely in Nigeria. So I'm very pleased that our colleagues are here with us today. And so this presentation will be in 3 parts. The first part will be led by Andrew Salmon, who is my colleague from Tearfund in Nigeria. And he'll be joined by Jane Woki from Faith Alive Foundation, one of our partners, and David, who is from Team CEDA. And then the second panel will be led by Dr. Brian Shaw, who is the senior researcher from the Institute of Reproductive Health at Georgetown University. And then the final section will be with 2 of our implementers in the community. So that will be our faith leader, Reverend Joel, as well as a gender champion, Ladidi Manan. And you'll hear more about what a gender champion is later. So I'd really invite you to share your questions in the chat box. We will hopefully have time at the end for a question and answer. So please also ask them there. But next slide, please. So these are the main partners that were involved. So the Institute of Reproductive Health, Tearfund, Faith Alive Foundation, and Team CEDA, as well as receiving funding from the John Templeton Foundation for this. I'd now like to pass to Andrew Salmon, who will lead the first panel.
Yeah, thanks, Luke. Good day, everyone. My name is Andrew Salmon. I work with Tearfund Nigeria as the project manager for the Masculinities, Faith and Peace project. I'll be giving us a brief overview on the MFP project, which actually focuses on 3 key areas. The first is social cohesion, which is basically to improve interreligious relationship between Christians and Muslims. and also to SGBV, which is also to reduce intimate partner violence. And thirdly, the third area of focus is family planning, which is to increase healthy timing and spacing of pregnancies. Next slide, please. Next. Yeah, so just to briefly talk about the timeline, it's actually the MFP is a 3 years project, it's a research project to be precise, which commenced in 2018 with a kickoff orientation. And then we also had, the co-creation phase where we adapted the tools that were used, because it's an intervention which TFN has been carrying out in some other parts of the world. We adapted the tool to make it an interfaith intervention, being a faith-based organization here in Nigeria working in this field. So we had the tool curriculum adaptation to suit the Islamic context, which was done between November 2018 and January 2019. We also did some baseline surveys, which Brian will be throwing more light on that. We also we now started with the pilot testing to test the tools to ensure it's acceptable by the people in the community, and which was done in June. So after the pilots, we decided to do a full rollout, which we started training in September. And then we had the 3 cycles of the intervention between October 2019 and October 2020. And after implementation, we had a global dissemination and a local dissemination, which was done in April, and the global dissemination was done in June, which was the end of the project. Next slide, please. So the project was actually implemented in 5 local governments in Plateau State, which is in North Central Nigeria. And as you can see in the map, we had, because it's a research project, we had experimental sites and also control sites. So the red indicators there you can see are the control communities, and then the experimental are in blue. Most of the communities were done in Bassa, Jebubasa local government, in Jos South, Jos East, and Jos North, and then one other local government down southern part of Plateau, which is Shandam local government. Next slide, please. So that was where we carried out the intervention. So we had 2 rural communities and 2 peri-urban, 3 rural communities and 2 peri-urban for both control and intervention sites. So just to give us an overview of the project, we worked with Gender Champion, just like when Luke was introducing the MFP project. We worked with religious leaders, being a faith-based organization, who were trained on the Transforming Masculinities model to engage them in personal reflection and provide leadership and support for the project implementation with reflections from the Bible and the Quran. And then we also have gender champions who are identified by the faith leaders as agents of change at the community level, who are also respected people and influential people, because these were some of the criteria we tried to ensure before selecting the gender champions to work with. So the gender champions actually conducted community dialogues, which is a structured kind of form of conversation done in 8 weeks. And then while the religious leaders led, diffusion messages, which was carried out in churches and the mosque based on all those themes that will be seen on the next slide. Next slide, please. So for the sermons carried out by the faith leaders in churches and in mosque, we had different themes in which they were discussing about, and these are the themes: support for survivors, gender equalities from the biblical and the Quranic reflections, Jesus and Muhammad as role model of positive masculinities, child spacing, positive parenting, and also family well-being, gender roles and norms reflected from the scriptures, and also religious tolerance and peaceful resolution of conflict, male involvement and household and childcare. So all this while being integrated in their sermons. We also have the gender champions who take note of the themes being preached at every point in time, which they also meet with people in groups, have group talks and other platforms of their meetings in the churches and in the mosques. Next slide, please. So for the community dialogues carried out by the gender champion, like I said, structured in such a way that is done within 8 weeks for each cycle. The first cycle, for the first week of the meeting, they meet in single sex group, week 1 to week 5. And these are the topics that are being discussed: introduction to sexual and gender-based violence and its root causes. In week 2, they talk about gender norms in daily life. Week 3, they talk about power status and SGBV. Week 4, faith and SGBV. And then week 5 actually reflects on moving forward and So the female gender champions meet with the women, while the male gender champions meet with the men. And it's an intervention which is made for husbands and wives, but though they meet separately within the first 5 weeks, week 6 to week 8, they actually meet as couples now, where the gender champions facilitate the sessions. And week 6, they look ahead, envisaging communities free from SGBV. And in week 7, they reflect on child spacing and its benefits, childcare, male involvement, and all that. And in week 8, we talk about positive parenting, child spacing methods, which health workers come in to discuss the child. So the churches meet, as a Christian group separately, while the Muslims do the same. Then in week 9, they have a joint celebration for both Christian and Muslims, and they also reflect and discuss ways of peaceful coexistence and all that. Can we move to the next slide, please? Next. So just to quickly talk about the tools we used, we have the Transforming Masculinities tool, which is for training of the gender champions and the faith leaders. And another tool we use is the Community Dialogue Facilitators Handbooks, which the gender champions also use to facilitate the community dialogues. And we also have the implementation guide, which is developed for Transforming Masculinities model to help us, scale the project to more communities and places where TF1 is working. So this is just a brief about the implementation. So I would like to, at this juncture, to pass back to hand over to Luke. Luke, over.
Great. Thank you, Andrew, and thank you for fitting quite so much into a very short time. You did very well to fit so much in. Just to flag that we do have a quick guide to the MFP program. So if you'd like to know more about the technicalities, we do have that, and we can share that afterwards if that's helpful. I'd now like to welcome Jane Woke and David Okpatuma, who are project officers for Team and Faith Alive Foundation. Jane and David, are you both with us?
Yes, good afternoon.
Hi, Jane. Welcome.
Hi,
yeah, good afternoon.
And David's here as well. Thank you. If connection is a challenge, then please feel free to turn off your video, but it's great to see you while you are here. We're going to take the next few minutes, about 5 minutes, to ask a few questions of Jane and David, their experience of implementing. So let's begin. I don't mind Jane or David who'd like to answer this question, but I'm curious what was different about implementing MFP, which is a social norms intervention, compared to other projects that are less about social norms. Jane or David, would you be happy to answer that question?
Yeah, good afternoon. What's made the difference is that MFP is faith-based, and MFP works with couples. They also worked with faith leaders in the community who are the gatekeepers. And because of MFP, couples worked together during community dialogues, and it made it very, very unique. An integration of family planning is a very good one because cycle beats was something that is very rare before, but with MFP, it came into existence, and some of the myths about use of FP was also handled through MFP. So those was what made the project so unique.
Thank you. Yeah,
Okay,
definitely the role of faith leaders, and there's different components. Thank you. And
yeah,
David,
I think
same
maybe
question to you.
I might just add a voice to that. One very unique thing about the MFP project that's made it so unique and different is the community dialogue sessions, and then the faith leader. Though she said about the faith leader, but also the community dialogue, because it brought in couples together where they have from week 1 to 5, you have the male couple, the male participants having their sessions different, and then the other female participants who have their sessions different, and then in week 6, they all come together, a combined session from week 6, week 7, and week 8. And then in week 9, they have the celebrations, and then the celebrations involve the Christians and the Muslims. So it makes it so unique, bringing the two faiths together. I think for us, it's a great achievement.
Thank you. Yes, and you both spoke about the role of faith leaders to be influential, to change some of those norms and to see effectiveness. Could you speak a little more about the role of faith leaders and what made a difference with them?
Yeah, for the faith leaders, I think their role there, they play very, very huge role, in the sense that during the community dialogues, they usually come there to see what is going on. They participate, some of them, they participate in the community dialogue where there are some scriptural verses that the community members might not really understand. And then with the presence of the faith leaders there, they actually let them have a better understanding of those scriptural verses, be it from the Quranic or from the biblical aspect of it. So I think the presence of the faith leaders attending the community dialogue too, just to monitor and see what they're doing, it's play a very, very huge role during community dialogue sessions. And I think one major role too the faith leaders played was also the disseminations of the community dialogue, the dissemination of the projects where they have a wider congregations, and then they talk very well about it, and then you have a very good spread down to the communities and their congregations.
Thank you. And Jane, in the interest of time, I'd like to ask you another question, Jane, and that's about working in interfaith communities where there's a history of conflict, and what your experience of that was, and how the project overcame some of those challenges.
Okay, initially when we entered into the community, they had history of conflicts. But with MFP, the community members were brought together first through trainings of the faith leaders. The Muslims and the Christian faith leaders were trained together. The community members were recruited as gender champions and were also trained together. So the challenges we faced was mistrust among each group. But with the trainings, they came together and discovered that they have a lot in common for good. And during the trainings, they were exposed to the role models in the scriptures, in the Holy Quran, the Holy Prophets, and Jesus in the Bible. So it opened their eyes and fostered more unity amongst them. So working with them initially, we had challenges, but with the community dialogue sessions, couples meeting with other couples from different faiths, and also the celebration. This celebration helped a lot in fostering peace among this once troubled community. And another thing is the establishment of community mobilization, where the faith leaders come together to meet and talk about issues in the community that concerns both faiths. Even during that time, COVID-19 committees were set up among both faiths. So it helps in solving some of the challenges that we had when we went into the troubled communities.
Thank you. Thank you, Jane, and thank you, David, for your insight there. Again, so much in such a short period of time, and we hope that we can hear from you later as well. So thank you both. If you could bring the slides up now, please, again. I'm going to pass to Dr. Brian Shaw, who is the Senior Research Manager at the Institute of Reproductive Health. I'm sure he will agree that this project has led to some really exciting results and very promising results that are hopeful for the future. I'll let him say more about them, but I know he shares my excitement and my pleasure of seeing this project. So Dr. Brian, over to you.
Absolutely, and thank you, Luke. And it was wonderful to hear from David, Jane, and Andrew on the project. Now I'm going to speak a little bit about a fairly rigorous evaluation that we did and focus in on some of the select findings that this faith-based norm-shifting intervention was able to achieve over a relatively short time frame. So if you go to the next slide, and then, so I'm going to briefly talk about the methods, and then we'll get into the results. So really quickly, there were a couple of guiding research questions that we were interested in trying to get some information on. To what extent does the MFP intervention promote shifts in normative environments and behaviors related to modern methods of child spacing, to reducing experience or perpetration of intimate partner violence? And when we're talking about intimate partner violence, we're talking about male perpetration of intimate partner violence against women. A third research question, does the MFP intervention increase male engagement in childcare and household work? And then a fourth, which was the innovation from this is the MFP is a scale-up model from previous iterations, and now we're adding this social cohesion and interfaith dialogue piece. So we're very interested in what kind of changes that the intervention has led to in each one of these research questions. So the next slide. So I mentioned it was a very rigorous design. It was a cluster randomized control trial. It was mixed methods. So we did longitudinal quantitative surveys. So with the same program participants and control individuals from baseline to endline. And then as well, we did qualitative interviews. So the quantitative surveys we did, in order to qualify for that, a woman was 18 to 35 years old of age, married or cohabitating within the last 5 years, and no children older than 5 years of age. And then as well, their male partners of any age. So this was the criteria for the intervention as well as the research. And then for the qualitative, we also, in addition to program participants, also did some interviews and focused group discussions with the wider congregation members that were more indirectly touched by this program, gender champions and faith leaders. You'll be hearing from some of them in our next session, as well as health workers. So that was our research questions and how we went about trying to answer those research questions. So first, I'm going to focus on our child spacing findings. And I'm mostly going to just talk about our indicators that were for social norms and for the actual behavior of use of child spacing methods. So this first slide demonstrates some shifts in the social norms for use of modern child spacing methods in faith communities. On the left, we were interested in perceptions of approval of newly married couples. We realized that social norms may be different from newly married couples. And then on the right, it's for perceptions of approval of first-time parents. So we asked the participants whether they thought their fellow congregation members or their faith leaders approved of newly married couples or first-time parents using child spacing methods. This is just showing the intervention participants, but what we see is about an improvement of about 10% in those individuals that think that the congregation perceives that the congregation approves of modern methods of child spacing for newly married couples, and almost 20% for those that perceive that their faith leaders approve from baseline to end line. So we're seeing for both newly married couples and first-time parents, from before the intervention to after the intervention, we're seeing increases in those respondents thinking that their faith communities are more supportive of both first-time parents and newly married couples using child spacing methods. So we are seeing some decent shifts in norms around the use of child spacing. We also saw, I don't have the data, or we're not going to have time to show the data, but we also saw a lot of significant improvements in individual attitudes, in self-efficacy, in couple communication, as well as relationship quality around this use of child spacing. And this is particularly for first-time parents. This improvement was statistically significantly larger in intervention areas compared to control areas. So we do really see some shifts in social norms, and those perceptions of is child spacing acceptable to faith communities, and is it being practiced in faith communities? Next slide. So we did see, so this is for actual changes from baseline to end line and the actual reported use of a modern method of child spacing among non-pregnant couples only. So we did actually see over just the 18 months of an intervention, a pretty large jump from 44.6% of respondents saying that they were using a modern method of child spacing at baseline to almost 60% at end line in those control areas. So there was a large jump over time. But we also saw this occurring in the control areas. So we're still trying to figure out, a little bit about what's going on. Why are we seeing this significant improvement in both the intervention and the control areas? So even though we saw significant shifts in social norms relative to controls, it looks like, this behavior of using child spacing is improving both in control and intervention areas, but significantly so, almost a 20% jump. Or 15% jump from baseline to end line. So if you go to the next slide. And we have some qualitative quotes that really sort of demonstrate the power of this change. So yes, MFP, it has enlightened people in the sense that you won't hear any conflict about child spacing because we have all seen the importance. They've opened our eyes and we know that this child spacing will help us. And honestly, it has helped us and we've seen it. And the changes are obviously seen. So this is from a Christian woman in Jebu Bassa, a congregation member. Now, if we go to the next slide, I want to focus a little bit on the intimate partner violence findings. And then the next slide. So here, we did again see some slight shifts in social norms for acceptance of intimate partner violence in faith communities. So on the left-hand side, you'll see the pink baseline and the red end line for those respondents that perceive that their congregation approves of using violence to discipline wives. So we want to see that going down, and we see that decrease from about 15% to about 5%. And then for faith leaders, we see that drop from about 10% to 3%. So it was already fairly not accepted within these communities at the very beginning of the intervention, but it became even more unacceptable over the course of the intervention. Next slide. So here we saw significant improvements. This is just showing, the sort of prevalence of those that reported that they had experienced or perpetrated an act of emotional intimate partner violence. So 61% at baseline reported this in the intervention areas, and that dropped to less than 40%, 38.8% at end line. So we're seeing over almost a 25% drop in the prevalence of reporting of emotional intimate partner violence in intervention areas. Next slide. And we also saw that for physical as well. We saw in the green is the control, is the intervention area. So in the before the intervention, 18.3% of men reported that they perpetrated physical violence, or women reported that they experienced intimate partner violence. And that reduced nearly 10% down to about 10% of the total sample at N-line. So we're seeing relative to the controls that there is significant reductions in physical and emotional intimate partner violence. Next slide. So here again, just sort of a quote further demonstrating this. Previously, everything was blamed on the women. The woman was said not to have any rights, and everything should be blamed on her when she didn't have any respect. But now a lot of knowledge has come, and the realization that whatever is done together would make everyone run together. And go to our final social cohesion, and this is I think where we had a lot of the most powerful findings. So if you go to the next slide. Now, on the intervention is on the left-hand side and the control is on the right-hand side. So we asked, do you perceive that religious conflict is common in your community? And that dropped from almost half of the respondents saying that prior to the intervention to only 27.7% at N-line. So we see significant reductions or significant perceptions of conflict being less common in MFP communities. Next slide. The same is with mistrust. So about half thought that there was mistrust between Christian and Muslim communities prior to the intervention, and then that dropped to less than 30%. So that we saw significant improvements in that in the intervention areas that we did not see in the control areas. And then the final slide. Can you go to the next slide? And then here as well, we're showing growth in intervention areas in those that respond, the religious leaders work together across faiths to solve community problems, where we actually saw a reduction in control areas. So I'll stop there, but by and large, we saw significant improvements, particularly in intimate partner violence outcomes and in social cohesion in MFP areas that we didn't really see corresponding changes in the control areas. And then for child spacing, we actually saw significant improvement over time, but we saw those in both areas. So a relatively good story overall, and maybe just to really bring it home, now is better than before, because now there is a more understanding than before. And now, in fact, the other day, a Christian brother paid for my transportation on a motorcycle. I don't even know him. Maybe it's the MFP project, meaning that he knows me. And you could read the rest of the quote. But quotes like these and these findings are just really demonstrating that a faith-based norm-shifting intervention like MFP is just really having a lot of positive impact in these communities. And I'll stop there.
Thank you, Brian. Yeah, it's great to hear some of those statistics and that learning that is coming out. And I know you've been working a lot on comparing that with other research and seeing that this is a really, really exciting project with the results that are coming out of it. So it's great to hear a snippet of those, a small amount of those. Before we go to our final panel with our faith leader and gender champion, Brian, I'd like just to hear about perhaps the gaps that might still exist. Is there anything that you think is really missing that we could still be learning about? Of course, there's everything, but what are the gaps that you would like us to learn more about?
Yeah, I mean, from a research side, I'm very interested in what kind of impact these sort of community cohesion and social cohesion might actually have on, for example, intimate partner violence. So that's something that we're taking a look at right now. Does, a more cohesive, socially cohesive community lead to less intimate partner violence? That seems like a sound assumption. So that's something that we're taking a look at, and that might, show that there's even more positive benefits to MFP. We're very interested in, it seems for, family planning, for example, it seemed like norms shifted, attitudes shifted, self-efficacy, a lot of things shifted positively in intervention areas compared to control areas, but we're also seeing that increase in control areas. So it'd be interesting to know why that's occurring, and also about, perhaps all of this work that's been done with attitudes and social norms might cause that to sustain for longer. So it'd be interesting to have follow-up and to know how much these behaviors are holding. And then finally, just to really better understand, diffusion and the way that these messages, the MFP messages, are sort of diffusing through the community outside of the target group to the wider congregation. I think those would be a lot of very interesting things that I would love to understand about how MFP seems to be having such a very strong effect.
Thanks, Brian. Yeah, it's great to hear the kind of complexity amongst the successes and, you know, those nuances, I guess. So thank you for sharing those. I'd like to now come to Reverend Joel and to our gender champion, Ladidi Maman. Are you with us at the moment? Can you hear?
Hello. Good afternoon. Good afternoon, sir. I can hear you.
Hi, great, thank you. Great. So we've heard in this presentation what the MFP project is. We've heard a little bit about the results. Hi.
Yes,
and
sir.
now we're going to turn to Reverend Joel and to Ladidi to hear a bit more about what it is like to be part of this project. What does it feel like? What is the change in the community, and how change has happened for them and with them? So a question that I'd like to ask to both of you, to Reverend Joel and to Ladidi, is why were you interested in the MFP project to start with? What drew you to this project?
Let me respond first. Actually, the MFP program has been so interested, particularly to me. And I remember the fateful day Jane and Gloria came to the church and introduced me to this program. Truly, I said I will not miss that opportunity, because it's an opportunity to meet with other faith, an opportunity to come closer to Muslim counterparts. And therefore I said I will not leave this opportunity. And truly the training has been so impacting in my life. And therefore it's very, very interesting. I would say to the initiators, keep it up.
Good afternoon all.
Yeah.
Good afternoon all.
Yes,
Thank
good
you
afternoon.
very much for having me. What makes me interested in the program, in the MFP program, when they came for the baseline 2019. So I was introduced through my faith leaders. So they talked to me about it. I now read it, my manifesto. I found it very interested for the program. And it changed me a lot because of the coming together between the Christian and the Muslim. It has never been done before. So during the training, we stay together with the Christian and the Muslim. We all stay together, and I find it very interesting, and it really changed me in theory.
Thank you both. Thank you. And you mentioned there about change and personal change. And a question I'd like to ask you, Reverend Joel, is what was a personal change that you experienced through this project? And what do you think caused that?
Yeah, truly, there are a lot of changes, especially in our community. Because you can see us mingling together, coming together, discussing with the leaders, the faith leaders in Muslim communities and the Christians. Especially when I go to their community, they are so happy seeing me in their community. And anything I want to do in that community, they welcome it. Especially in the issue of crisis, I realized that there are a lot of changes, because any crisis that will start, or when we see the sign, we'll call ourselves in the community, the Muslim leaders and the Christian leaders will sit down and make sure that those things that we're foreseeing will not happen in our community. The recent example is what happened in August 2021 in Plateau State, particularly Just North, because of our meeting, because of the program of the MFP, has helped us truly that nothing happened in our communities. We talk to the young people and they listen to us. So what has not happened before, in fact, is really happening now. And I want to assure you, Brian, that the Muslims saved over 50 of my members who went into their communities for immunization, and the crisis erupted. Because of the meeting we do have with them, they said, no, we will not allow anything to happen to these people because we are always having peace dialogue with them. And therefore, some of them were hidden in different places in their communities until the security men came and then picked them up. So I believe there are a lot of changes that is happening in our community. And we'll pray that we will continue. We'll do our possible way to maintain it.
Thank you. Yeah, thank you. And that's, Reverend Joel, that's a story that I had heard as well, where Christian lives were saved by Muslims who were making sure that they were safe after this project. And I was so encouraged. So I'm pleased that you could share that story as well. Ladidi, I'd like to ask a similar question to you. Ladidi, as a gender champion, you were meeting regularly with the community dialogue participants and hearing stories about their families. Could you tell us about the changes that have been happening in people's families as well as the community?
Thank you very much. There is a lot of changes that happen in my family and in the community. Before the coming of the MFP, it's hardly to see the Muslim and the Christian come together. But since the coming of the MFP program, the Christian, they even came to my house during Salah to celebrate Salah with me. So I'm very, very happy for that. It has never been happening before. And a lot of couples in my community now, they accepted the family planning, especially the cycle beat. Before they are thinking that they are denying them of having children. But since the coming of the MFP and with the scriptures, some scripture of the Quran to back up, they now believe that it's just for them, it's for their health, being not for them to deny them access for the having children. So they now accept it. They now accept it and they are very happy because of their health.
Thank you, Ladidi. Yes, it's so exciting to hear about the different aspects of the project and some of those norms around the healthy timing and spacing of pregnancies, and communities learning and reflecting on how that can be a really good part of their faith as well. And Reverend Joel, I'd like to come to you. As a faith leader, how has MFP affected how you practice your faith and also the faith of your congregation?
Truly, the coming of this program has widened my horizon, especially in terms of proclaiming the gospel. And I want to say that I look at this, that we don't have any reason to fight Muslims. Since if you look at the Quran and the scripture, they are all emphasizing on peace, on peace, on peace. We don't have any reason to fight each other. So in my message, especially on the pulpit, I speak strongly on the issue of living in peace, because Jesus Christ is a Prince of Peace, who taught us that love your enemies and even pray for your persecutors. So if we are to follow that scripture, really, I believe we will not have any cause to fight Muslims, because they are all created in the image of God. And truly, I can see that in my church that I'm pastoring, because there are a lot of couples that participated in the community dialogue, which has helped them very, very well. And I believe strongly that this program, if we maintain, pastors will not have some headache. for them, they'll be rejoicing because truly something is happening in the family. And if the family is well, the church is well.
It's such a good point, isn't it? That the church doesn't operate by itself, but families are what make up the church, and also mosques as well. So yeah, such a great reflection. Thank you.
Yes, sir.
One to Ladidi possibly, but also I'd like to come back to you, Reverend Joel, on this as well. Is about engaging with faith communities, and what were the challenges of engaging with faith communities to improve the health of community members and couples and the community at large? What were the challenges for engaging with faith communities? Perhaps Ladidi, you could speak first on that one.
Challenges that I face in the community, they thought that they are going to convert them to Christianity when the MFP come. So during the community dialogue, having Quran to back up, we now realize that it's regardless of who you are. So a lot of people, they now accept it, and they now know that it's not that they are wanted to convert them from Muslim to Christian. No, it's not done that. It is just for them to have peace, because Islam itself is peace.
We seem to have lost you there, Ladidi. So I'd like to come to Reverend Joel, and perhaps you could speak how you'd like to, but there was that point there about the Quran having similar messages for some of the topics as the Bible, which is why the manuals are both, they have biblical references, and we have another version which has Quranic references.
Yes.
So perhaps you could speak a little bit about that, and anything else as well about engaging with faith communities there.
Actually, like I was talking, Matthew chapter 5, from verse 43 to 49, Jesus says, "You have heard that it was said that love your neighbor and hate your enemy. But I say that love your enemies and pray for those who persecute you, so that you will become children of heaven." Because if we love those that love us, even the pagans also do that, then what is the difference? So we must be perfect as our Heavenly Father is perfect. So I believe strongly that if we take this Bible reference serious, truly we don't have to fight Muslims, because Jesus is the foundation of peace, and he is the Prince of Peace. He also added that if your enemy is hungry, if Romans chapter 12, verse 9, following, he said, if your enemy is hungry, give him something to eat. If he's thirsty, give him something to drink. By doing that, the enemy will know that, yes, you are overcoming evil with good and not good with evil.
Thank you. Yeah,
Sorry,
great reflection there.
It's connection problem. Yeah. So I would like to add, as I was saying, itself is peace. Prophet Muhammad sallallahu alaihi wasallam accommodated, during his lifetime, he accommodated Muslims. He even treated them as one of them, as Muslim. So I didn't see anything wrong between staying Muslim and Christian being together for peace. There is nothing like we should be fighting each other. No, the Quran did not taught us that. Prophet Muhammad did not practice violence. He practiced peace. So Islam is peace. It's all about peace. So a lot of people in my community, the couples, they now realize that because of the Quran, the scripture that we are backing, so they now know that peace is all about peace. You can never achieve anything without peace. So Alhamdulillah, a lot of are accepting because they are now not seeing now in my community, the couples. If Christians they are having a program, they invited Muslim. And if Muslims are having anything in their mosque, they invited Christian. So they come together and share peace. So because of the MFP program, they now realize peace is very important in our community. So Alhamdulillah, a lot of things have changed since the coming of the MFP program.
Thank you very much. Yeah, thank you. In a moment, we are going to watch a very short segment of a video. So the final question that I'd like to pose to you both is that some people, and there's a perspective that faith communities can be very slow to change and to bring about change. What would your response be to people who view faith communities as very slow to bring about change?
Okay, let me respond before Ladidi will maybe add. One thing I believe is change is a gradual process. If you want it to be an automatic, I think sometimes it will be difficult. But I believe with the coming together of the faith leaders, what we are doing, in fact, we really thank God that there are a lot of understanding coming out based on the community dialogues, on the trainings we have received. Truly, before, I don't know about MFP. But when I was introduced and trained and understand what all MFP is all about, you see, I have a changed perspective towards life. So I believe strongly that gradually we will continue to preach this program and we'll continue to act, put structure on ground, put our activities. And I'm so happy, Luke, to tell you that Jane came to our community. We have a celebration. We had a football between Muslim and Christian. In fact, we are so happy with that program. It has given us a good synergy between the two faiths. So I believe whatever people may say, as a leader, it will not sidetrack me or will distract me. I know where I am going and I know what I'm carrying. I believe they will see action and not just to say. Thank you.
And Ladidi, would you like to add anything to that? Can you hear us, Ladidi? I think it's frozen at the moment. Okay, we will come back to you, Ladidi. But first, we're going to just show a very short extract from a video that was produced to show the MFP project. Marilyn, are you able to share that? Thank you. Just from, I think, 3 minutes 20 to 5 minutes. It seems to be trying to share the screen, but it's not showing.
Marilyn, let me know if you want me to try on my side, because we don't see it yet.
Yes, please. In the interest of time, you might want to. For some reason, it's not.
Okay, let's see if I can pull it up.
Can you see it now?
I don't see it yet.
Oh yeah, I'll just stop sharing.
Okay.
So na fi son sosai program kenan.
Is this the right spot?
Yeah,
Luke, go ahead and you can hear the sound.
Yes.
Great, here we go.
Gaskiya mun yi musu magana sosai saboda inda abin da SGBB yake kwato saboda ko ina da ma makwabci wanda da yana dukan matan shi, amma saboda dalilin wannan program ɗin inda na zaunar da shi, matan na fara zauna na mata magana, na nuna mata cewa in akwai wani abin da kike yi wanda ba daidai ba ke kin sani ya kamata ki canza. Sannan na ce ina so in yi magana da mai gidanki, kuma na yi ƙoƙari na yi magana da mai gidan, kuma na ji daɗin yadda suka yi ƙoƙari suka ji sun gyara. Da kullum a holo in aka ji holo za a ce gidan wane ne, amma saboda wannan abin ya zamanta cewa sun bar wa'annan abubuwan kwata-kwata.
Gaskiya koyarwa nan musamman nakan ba da example a kaina ne. Ya taimake ni, ya taimake rayuwana, ya taimake cikin gidana, ya canja mai gidana, ya canja shi. So idan har koyarwa nan an ci gaba da shi haka kamar bishara har wurin su sun ji haka, ina gani a cikin gidajenmu ba za mu samu matsala sosai ba. A zama a community da mu da Hausawa ba za mu samu matsalan da abu kadan zaki ga ya kawo damuwa ba, domin mun riga mun ji koyarwa nan ya taimake mu sosai.
Za a haɗu a haɗa kai a dawo abu ɗaya kamar da. In dai aka ce kamar za a ware iya munar ku ta amana nan cikin Jos ba su sani ba, to ka gani kamar ba a so a yaɗa abin da ake so a isar ba. Amma in munar ku ta mun samu, Jos sun samu, Babala sun samu, Yalwa sun samu, to kaga duk za mu haɗu ya zama abu guda ɗaya. Kowa da kowa sako ya isar masa.
A lot of women are carrying out the fertility awareness method and they don't really know how to go about it. With the MSP program, it has built their capacity.
Thank you. So that was a very short segment from the video. I have shared the link as well as the Endline report there as well. So if you would like to view the full video, it's about 7 minutes, you're very welcome to. I'd like to invite back Jane and David, Andrew and Brian to join Laditi and Reverend Joel to take a few questions in the final 7 or 8 minutes that we have from the audience. So thank you for sending some questions through. If you have more, then please do share them. Perhaps I could open it to the floor. If not, we could take one from the comments box.
Luke, we do have 3 comments from the comments box. Linking straight off of the video, for example, Biaya asked, what are the intentions to extend the programs to other communities, especially other post-conflict or conflict settings? Maybe you or Andrew?
Andrew, can I invite you to share on that? If you're speaking, you're on mute, Andrew. Okay. Can the host unmute you? Yes.
Okay, thanks very much. I've just been unmuted. Please, can you repeat the question again? I was busy. I didn't get the question well.
Yeah, Biaya asked, what are the intentions to extend the program to other communities, especially conflict and other conflict and post-conflict settings in Nigeria?
Okay, thank you very much. That's a very good question. Basically, to talk about that, I think we all are aware that the society or the area we're living with is a plural, let me say, society characterized by the people from different religion, beliefs, and all that. So as a result, it's a community-prone conflict. So basically, what we're doing is Tier Fund. From the MFP project, you can see the components because there are 3 objectives which you set to achieve, which is the social cohesion, child spacing, and also intimate partner violence, reduction in intimate partner violence. There are plans, actually, we're planning to scale up. However, we are also looking for a potential donor who will be able to invest, because 3 years project are finished, even though we've gotten like a year extension through IRH on the Passages project, which would elapse by June next year, and we don't have much resources. So when we're able to get a donor out, want to put in some money for us to carry out, we'll be happy to scale it up, because our plan is to scale it up to 20 communities, because we've worked in just 5. From 20 communities, we are looking at the long run, maybe scaling up to 50 and possibly 100, and not just in Plateau State, because this is the pilot which we've done in Plateau State. We're thinking of taking it to other neighboring states, like in the middle belts, like Kaduna, Bauchi, places like Nasarawa, Taraba, Benue State, and all that. So it's basically about funds. We have a concept note that's, all these are spelled out there. So if we have the fund, we would swing into action. But for now, with the support we've gotten, we're doing just 10 communities with the same strategy. But yeah, there are plans, but then funds make it possible for us to scale up to more communities as we have planned.
Thank you. Yeah, thanks, Andrew, and great summary. Just very briefly before we go to the next question, we have developed an implementation guide, which includes the MFP program, which will really help us to scale further and to look to refine it further as needed. So that's there as well. Brian, so there's a few questions. Would you like to share another one there?
Yeah, I saw another one from Jared Miller. This might make sense for like the Didi or David or Jane. So can you share an example, a specific example of a social norm that the project worked on during one of the dialogue sessions, and maybe how you saw it change?
Okay. Hello, one of the social norms in the community concerning family planning is that a woman must take permission before going to the clinic to access FP. But with community dialogues that took place in the community among couples, the norms were changed, because now men went, not only giving permission, they also went with their wives to the clinic to assess family planning method. That was one. Then secondly, before the community dialogue, in some communities that we worked in, a man cannot be found sitting with a woman. But with the community dialogue at the week 6, men and women come together to dialogue. Initially, when they started, women found it hard talking. They found it hard even sitting down where men was. But with the community dialogue, they started sitting down with them, to the extent that one day a woman held hands with her husband. She was laughing throughout the project, and she said that this is the best day of her life. So most of the norms in the communities were really handled through community dialogue MFP project.
Thank you. Thank you. We probably have time for one more question. Is there one more in the chat box? I can't see one.
There was from Godfrey about what the retention rate of participants during the community dialogues during that 8 weeks period. So I think, how many did we retain from signing up to the intervention to the end, which Andrew might have some.
Yeah, right. Yeah, Andrew, in the last minute, would you be able to answer this before we wrap up?
Sorry, I've been experiencing some network distortion. Look, I didn't get your question. What was your question again?
So the question was, so what proportion of participants that started the dialogues finished the dialogues? So what is our retention rate, I believe?
Honestly, I would say 99.9% of participants that started from the beginning to the end, because we only had one case where there was this particular couple that was attending the community dialogues that was transferred, I think, to Lagos. So as a result, we couldn't allow his wife to continue or capture her as completed the cycle of the community dialogue, because it takes the couple you get to, be part of the process to be certified that they've gone through the process, because it's an intervention that is designed in such a way to carry the couple together. But then if one participates and the other, no. So we've had over 772 couples that attended the community dialogues, and just one. So I would say we had 99.9% achievement with respect to community dialogue participants attending community dialogues.
So, okay. I think also to add to some of those, one of those norms is in the community members see the child spacing that they are trying to stop them from having children. That when they go for this method is to prevent them from having children. But over time, they've got to realize that when they went to the health facility, they were more enlightened. And then through the health talk from the providers, they've got to understand that it's actually not so, it's just a norm. So the MFP has really helped to clear off those norms that the community members were having, that the child spacing method is to prevent them from having children. So it has been accepted that it is not that, and then they are all partaking in the family planning method.
Great, thank you. We will have to leave it there as we come to the end of our hour. But thank you so much for being part of this session. I'm just going to share my email as well as Brian. So if you have follow-up questions, then please do send them to us. But yeah, I'd like to pass back now and thank you again.
Thank you so much. Over to you, Hasbiala. Do we have her? I know she was experiencing some network issues, so it looks like we might have lost her. Mikhail, will you close us out for today?
I think Hasbi has just joined.
Yeah.
Let's just give her a second.
Thank you.
Hasbi, are you with us now? Hasbi, over to you.
Hi, sorry. Hi, everyone. Sorry, I was battling with my bandwidth. Very nice presentation from all the speakers. It's been interesting conversations, but thank you. Thank you for joining. It's been a very, very long day of conversing and seeing all the dynamics of social norms. So just before we close out for the day, we have just one question to everyone that is still here. In one sentence or less, please share one insight from today's conference that you found most applicable to your work. I think you can please use the chat box for these. Can everyone hear me? And did everyone get the question?
Yes, we can hear you. Can you take the question again, Hasbi?
Okay, so this is the question. In one sentence or less, please share one insight from today's conference that you found most applicable to your work. So please, you can share your insight through the chat box, and we'll be reading and also collating responses. Thank you. So I'm just going to give 1-2 minutes for that, then we close out for today. Thank you, Meredith. It's in the chat box, so. I'm going to repeat the question again. In one sentence or less, please share one insight from today's conference that you found most applicable to your work. You can use the chat box, please, to answer the question.
Thank you so much. Thank you for availing yourself for this. We all did the work, and we all
Thank you, everyone. We'd love to hear more responses in the chat box. And I'm just showing a preview of tomorrow's session. We would love for you to join us tomorrow. We'll be starting at 1:30 again. We'll have presentations on gender-based violence as well as women's economic empowerment, including another panel discussion and abstract presentations. And in the chat box, I'm going to put the link to sign up for the Nigeria Learning Collaborative email list so that you can stay in touch with us on upcoming opportunities to get engaged. And we'll also repeat this information on day 2 closing session.
Thank you very much, Meredith. I'll also be sending reminders for tomorrow's session. Because if you have questions, clarifications, you can always reach out to me or any member of the team. And thank you for all the responses coming in through the chat box. They're very exciting and interesting to see. So I'll hand over to Meredith. You have some few words before we close out for the day.
Thank you. I think we're all set. Please do continue letting us know any key insights that came from today that were applicable to your work, and we'll repeat them tomorrow when we open the session. And thank you all so much. We will hopefully see you tomorrow at 1:30. And please do sign up for our mailing list. You can click on the link that's in the chat here. Thanks, everyone. And with that, I think we will end the meeting.